So welcome to the Renal OSPE review session. First, okay. So we're gonna be taking you on many different things. So we're gonna go through the posterior abdominal wall, the kidney, nephron, ureter, bladder, prostate, urethra, and then we'll end with a conclusion. We're gonna cover anatomy and histology and some like X-rays, ultrasound, all that. Okay. So starting off with the posterior abdominal wall. First, you guys, okay, so this is not really part of the posterior abdominal wall, but you guys have to know the lumbar vertebrae, okay? So can you guys tell me what view is this? Can you guys see my cursor? Is it showing? Yeah, thank you. Okay, what view is this?
Guys, come on, we made this as interactive as possible so you guys could
Yeah.
benefit.
And guys, it will help you remember. So
Sagittal. Okay.
so okay.
Any other guesses? Or are we sticking to sagittal? You guys are making me
Lateral.
live like a streamer with the two screens. It's honestly interesting.
Lateral.
View.
Okay,
Okay.
good job. Okay, so this is the lateral view. All right, now this second view, what is this? Frontal. All right. Anyone else wants to answer? Frontal view. All right, okay, good job. So this is the anterior view or frontal view. And finally, the last one, what is this? Cross
section.
Are you sure? I mean,
I see why you'd
I
say
get
that.
what, yeah, I get where you're coming from. Horizontal. Okay, but where am I looking at it from? Like if I'm holding one in my hand, where am I looking at it from? Superior. Good job. Good job. Okay. So what is the superior view? All right. Okay. Now, we want to go through some features of lumbar vertebrae that you might be asked about, but I want you guys to tell me what you know about it, okay? So let's start with the vertebral body. How does it look like? Like what's the
Massive.
Yeah, okay. Thank you. I think it would be better if you answer in the chat. I'm really sorry. But it's better in the chat so that we can
We'll have
hear you.
checkpoints in the middle where we ask you guys if you have any questions, just for the sake of the recording, so that like the voices don't overlap. But we really appreciate the
Yeah,
enthusiasm.
thank you so
Good job.
much. All right, so yes, large kidney shapes. Good job, you guys. Okay. Okay, what about the foraminum? What's significant about its shape? Triangular. Good job, you guys. Okay, and the transverse processes? What would you say about them? Please. Short and sturdy. I like the description.
Very specific. Good job.
Short and sturdy. All right. And the articular processes, the ones at the bottom. Hello, hello. The articular processes. Remember what they are for?
Can you guys hear us?
I think they can. Did something happen?
Yeah, I think it's fine.
Not sure. Okay, it's fine. We'll go through it. It's okay. Okay, now I noticed that you guys said short and sturdy about the transverse processes, but if you said that about the transverse processes, then what about the spinous processes? Don't you think that that applies to the spinous more? The short and sturdy?
Taking 1 to 3
Yes.
business days to for any answers to get through. So I think we can
Okay.
like hurry
Thank you.
up and just move on.
Thank you for the yeah. Yeah, you're right. Okay, so these these are the different features that you guys should know. Okay, so you guys got this one right, you got this one right. But however, the transverse processes are long and slender. Okay, so look back here. You see they're long and they're very thin. You can see from the spear view how thin they are. Okay, so that's something to keep in mind. Also, articular processes are vertical. So this is, you guys couldn't guess this one, but that's fine. Okay. And the spinous processes are the ones that are short and sturdy. All right. Fine. So now on to the real deal. Okay. So again, what's number one?
Which ones are the articular
Oh,
process?
sorry. Okay. Articular processes are these. You see, can I zoom in? Yeah. Okay, so you see these. You know how joints have
The
cartilage?
pointer isn't showing
Oh, sorry.
here.
Okay, thank you. Yeah. You see that? Okay, yes, diaphragm. The person who asked, did you get this now? The articular processes? Are they for yes, good job. Okay, so yes, they do connect with other vertebrae. You're welcome. Okay. Right, so number one is diaphragm. Good job, you guys. Okay, what about so number two is not really included with you guys. Okay. We'll go with number three. So what do you guys think number three is? Okay, I'm getting two answers. Which one is it?
This is
Oh, it's pretty lumbar. Good job, quadratus lumbar. Okay. Now, what about number four? Solus major. Good job. And number five, it's right beside it. Solus minor. Okay, and number six, iliacus. Good job, you guys. You guys are amazing. Okay. So here are the six muscles. Okay, the second one, we didn't really talk about it, but it's transversus abdominis. So it kind of like wraps around your abdomen. Okay. So we're gonna go through each muscle and its nerve supply and action. Okay, so quadratus lumborum, again, its nerve supply, it gets its supply from direct branches of the upper four lumbar ventral rami. Sounds a bit weird, but so you have the lumbar nerves, right? So the upper four, you have ventral and dorsal rami, right? So oh sorry, I'm used to the chat. Okay, yeah. So you get the first four lumbar nerves. You get these branches from the ventral rami of them. Okay. Okay. What about the action? So it's a lateral flexor of the lumbar vertebral column. All right. Now psoas major. Everyone likes this one because it's very simple. Okay. Its nerve supply is from also again L2 to L4, but the previous one was the first four, so L1 to L4. Okay. But here it's L2 to L4 ventral rami and the femoral nerve. Okay, so this is different. About now the action, which is why everyone likes it, is flexion of the hip. Okay, but it also has lateral flexion of the lumbar spine, but the main action is flexion of the hip. Okay. Now, obviously, psoas minor would be the same thing. Now, iliacus, this one, the one here, its nerve supply is from the femoral nerve, and action is also flexion of the hip joints, just like psoas muscles. And finally, diaphragm, the simplest dome-shaped muscle. It basically separates your thoracic compartments from the abdominal compartments, and its nerve supply is the phrenic nerve. Okay, this is really important. Sam, do you guys have any questions about the muscles?
You can unmute now if you want to.
No, all good. Okay. Okay, so moving on. Tamam. We have nerves on the posterior abdominal wall. Now I know you guys might hate this because they all look the same. Okay, but it's okay. We'll go through it together. So again, I'll be asking you guys questions. So the green arrow is pointing to a nerve. Can you guys guess which nerve that is? Iliohypogastric. Good job. Good job. I'm really proud. Okay.
You
What about
guys
the
are
blue?
smart, mashallah.
Yeah,
I have
mashallah.
to do the quote.
Okay. What about the blue one? Ilioinguine. Yes. Good. Good. Okay, and orange? This one. Nitrocutaneous nerve nodule. Yes. Okay. What about purple? Femoral. Be careful. Someone said genitofemoral. It's another one. We're gonna point it out later. Okay. Now the yellow one. Obturate. Yes. Okay, and finally the red one. Good. Now you can say genitofemoral. Okay, because it comes out from the psoas muscle, right? So good job, you guys. I'm really proud, honestly. Okay, so you have the iliohypogastric, ilioinguinal, nitrocutaneous nerve of the thigh. This one's my favorite because it's very easy to recognize. And then you have the femoral, obturator, and genitofemoral. Now, obviously, you guys have to know the roots of each nerve. So basically, you can think of it as the higher up it is, the earlier the nerve. So basically, iliohypogastric, since it's up, it would be L1. Ilioinguinal is kind of next to it, so L2. Okay, but then lateral cutaneous, you can see it's coming from two nerves, so that would be L2 and L3. And then you have femoral and obturator, they come from the same roots, L2, 3, and 4, but femoral is anterior and obturator is more posterior. And finally, genitofemoral is L2 to L4 also, but this one's significance is that it comes out from the psoas muscle. Okay, you guys got this part? Okay, good, good. Okay, so table, scary table. Okay, but it gives you the main actions, like the functions of each nerve. Okay, and unfortunately, you guys might have to know some of them. Okay, but you don't have to go through like very extensive details. But there are some things that are significant. Like for example, femoral, its motor function would obviously be the main gastric muscle because this is related to the genitals, right? Like you understand what I mean? Didn't you say in the previous time? Go. Oh,
Mhm.
oh, I might have made a mistake there. Yeah, that's probably a mistake.
Good catch.
I'm really sorry. Thank
Good,
you.
good catch.
Good job. Good job. Yeah. L1, L2.
Good job.
Yeah.
Sure.
Okay. So
So that's my name.
don't talk about it.
All right. Would you guys rather I use my own device so that like my name shows up just so it's easier to correlate like the different people, or is it fine? Yes? Okay, sure.
Okay.
Can you guys hear me properly? Can you guys hear me properly? Yes. All right, perfect. Okay. Now Naseel has been very nice to you guys so far. She's been taking you through everything and she's explaining stuff. I have a very different approach. I want you guys to answer a couple of questions, and through those, we'll be able to recognize the structures a lot better, hopefully, and we'll be able to actually see what we're trying to refer to. Now, you guys mentioned the diaphragm, and you were talking about this dome shape, right? So the diaphragm actually has three hiatuses, or three openings per se. They're not necessarily holes, but it's places where the diaphragm is a bit more, let's say, lax, such that it can wrap around specific structures. Given that information that I just told you, what do you guys think? Just a second. What do you guys think this structure is, the one pointed by the laser pointer and the arrow? Aortic, okay. Any other guesses? Aortic hiatus, all right. T12, aortic hiatus, okay. Very interesting. You guys are absolutely correct. Bismillah, mashallah. This is indeed the aortic hiatus, and it crosses at the level of T12. However, the other two hiatuses that we have, since the diaphragm has this dome shape, they're going to be at different vertebral levels, all right? They're not going to be at the same one since it's not completely flat. So to remember it, you just have to know that the aorta and the inferior vena cava, which both want to go towards the heart, love to hug stuff. So the esophagus is going to be in between, okay? Since they're going to the heart, it's about love, and they're squishing the esophagus basically in between them. Now, looking at that on this slide, you can see that you have two structures with one squished in between. The most posterior and immediately anterior to the vertebral column is going to be your aorta. This crosses the diaphragm at the level of T12. Immediately before that, at T10, a structure that is slightly towards the left side of the body because it's going towards the stomach is your esophagus. This crosses at T10. Now, above that, at T8, you have your inferior vena cava that basically just exits from like behind the liver and it just wants to go up immediately to the right atrium. Is that clear for everyone? Perfect. Moving on. Name the vessel marked as 4 and mention a clinical condition associated with it. Testicular, okay. Nutcracker syndrome. Good job. All right. You guys are absolutely wonderful, mashallah. So you are absolutely correct. This is the left gonadal vein or the left testicular vein, as some of you might have called it. Now, the reason why it is associated with Nutcracker syndrome is because, as you guys can see here, it drains not directly into the inferior vena cava, but into the left renal vein. Okay? So because of that, if you have any sort of injury anywhere here, which is a lot more susceptible, you're going to have this backup of the blood into the pampiniform plexus around the testicles, which leads to varicocele or varicose veins of the testicles. And this is what is called as Nutcracker syndrome. Is that clear for everyone? Yes, sir. All right. So very brief overview so that we can go over everything again. When I mention veins, I don't talk about branches, I talk about tributaries. What about 1, 2, and 3? All right, you tell me, what are 1, 2, and 3? So we mentioned, I think 2 is left renal, perfect. Which is right renal? Which one is the right renal vein? 1, perfect, yes. What about 3 then? Right renal, suprarenal vein, perfect, amazing job. So the reason why I think anatomy is actually fun to study is because you can sometimes figure out the name just by its location, right? So this vein is coming from the kidney, so this is renal, and this is going above the kidney, so it's suprarenal, all right? So try your best to just correlate it to the anatomical location. Even if you don't necessarily actually remember the exact name of the vein, you might be able to figure it out. All right. Now, I was telling you guys that when I'm talking about veins, I talk about tributaries rather than branches. And there's this mnemonic for the tributaries of the inferior vena cava. So we're going from down to up. That says, I like to rise so high, as will all of you, inshallah, as you progress in your career. So the I is for the iliac vein, which you guys can see is fusing here, right? So this is the first tributary. These will fuse together, and then they will soon be joined by the L, which is the lumbar vein. The lumbar vein afterwards will also get joined by the gonadal or testicular veins. Afterwards, you have the joining of the renal veins, the suprarenal veins from here, and finally the hepatic portal vein. So through this mnemonic, you guys can remember that we're making our way from the bottom up, and we like to rise so high through the iliac vein, lumbar vein, testicular vein, renal vein, suprarenal vein, and finally the hepatic vein, until we get to the actual inferior vena cava. Is that clear for everyone? Perfect. All right, moving on. A, mention the vertebral level where this bifurcation happens. L4, good job. And name the vessels which arise from this bifurcation. Common iliac, absolutely wonderful, mashallah. All right, so when I was talking about the inferior vena cava, the iliacs actually join together at the level of L5. So it's one vertebral level lower, as you guys can see here. At L4, we have the bifurcation of the the abdominal aorta into the common iliac arteries. So as you guys can see here, we have this abdominal aorta that then gets split into the common iliacs, the right and the left. After that, we're going to split even further into an internal and external iliac, hence the name common, right? Is that clear for everyone? Perfect. Now, when I'm talking about the abdominal aorta, I am not simply talking about just the common iliacs. We actually have so many branches popping out to supply different things. We have 3 unpaired branches, i.e., they're just one branch going to supply one thing. We have 3 paired branches, i.e., they pop up on either side to go up and supply things bilaterally. And we have the parietal branches and the terminal branches. The parietal branches are basically ones that go back into the parietal area, and the terminal branches are the right and left common iliac arteries at the bifurcation. Now, when I'm talking about unpaired branches, I'm not sure if the image is large enough for you guys to see, but if you see, as soon as the abdominal aorta crosses into the abdomen at T12, it's going to give the celiac trunk, which you will learn in GIT is actually what supplies everything that we have around the stomach, everything around the pancreas, the spleen, so on and so forth. So immediately, as soon as it comes down from T12, it's going to give the celiac trunk. Afterwards, I told you guys this is related to the GIT. So anything that's related to the GI will be somehow mesenteric. That is a name that we typically use when we're referring to the gut specifically. So we will be giving a superior mesenteric and an inferior mesenteric artery, which you guys can see here and here. The superior mesenteric artery is very interesting in the sense that it kind of hooks over, as you guys can see here, this vessel. Can you guys tell me what this vessel is? Left renal vein. Perfect. Good job. So this superior mesenteric artery, the way that you can actually very quickly and very easily find it is you see this hooking over the left renal vein. All right. Now the paired branches are going to be the median suprarenal artery, which goes up, the renal artery, and the testicular or the ovarian arteries, which go down to the testicles or the ovaries, respectively. Okay? Is that clear for everyone? Perfect. Now I've put that into a table for you guys just so that you can review it afterwards, but you already know everything here. You already know all of this. Just remember that the celiac trunk is going to pop up at T12 exactly. The other ones that I think you guys should probably remember is that the renal are going to pop up at L1, all right? And then the mesenteric are going to be with that because that is where you have the actual renal veins, so they're going to also be at L1. This is not very high yield, but just in case. I don't think it would come in the OSPE. It says L2 in the lecture notes. For which one? Isn't renal L2? I remember having this debate in first year very commonly as well, where we were like, okay, the renal artery should be L1 or it could be L2. Whatever it is in your lecture, just remember that. However, it doesn't really make that much of a difference since they're super close to each other. So whichever it is in your lecture, remember that. But both of them, it's basically between L1 and L2. So either one works. But if it's in your lecture as L2, just remember it as L2. All right? Moving on to something else. What do you guys think this pathology is? AAA. All right. Aortic aneurysm. AAA. Perfect. Yes. Abdominal aortic aneurysms. And I'm not sure if you guys got the chance to see it, but one of the cadavers that we have in uni actually has an aortic aneurysm. And it's very interesting to see. So an aortic aneurysm, as soon as you see this like huge puff, this bubbling up, this, yes, you saw it? Okay. As soon as you see this puffed up, thinned wall of an artery, specifically the aorta, you're going to think of an aortic aneurysm. And since this is in the abdomen, it's an abdominal aortic aneurysm. Perfect. Now, given what I just told you guys about all of the vessels, identify the vessel marked as 4. Internal iliac artery. Yes, amazing job, mashallah. So 1 would be our aorta that then bifurcates at the level of L4 into our common iliac arteries. And then afterwards, they will bifurcate into an internal iliac and an external iliac. 3 would be the lumbar artery, which is one of the parietal branches. It's not that high yield. Is that clear for everyone? Perfect. All right. With that, we come to an end of our posterior abdominal wall. This is a checkpoint for you guys. If you have any questions at all about anything that we just spoke about, you are more than welcome to ask us. What is number 3? It is the lumbar artery, which is one of the parietal branches that goes to the lumbar spine.
I have a question.
Mm-hmm.
So since we have said like number 4 is internal iliac, what about external iliac? Isn't like number 5 or?
Yes, yes, it is. So as soon as you have the bifurcation of the common iliac, you will immediately have an external and an internal. It doesn't give the internal and then continue as a common iliac to then give the external. I understand it looks like it's just one line continuing and giving a branch, but since I have a common iliac that splits, it is no longer common. It is now something that has divided. So the common iliac will split into the internal and the external, which you can see this is going more towards the medial aspect. So this is the internal iliac.
Okay, thank you.
Of course. Any other questions? Is there any clinical that they may ask? The only clinical things that you should expect in first year are just the things that we are showing you guys. Like they don't really focus much on clinical during first year. As third years, this is like when you focus a lot more on clinical. So in first year, just live your life. Don't stress out too much about clinical. You will be okay, inshallah. It is okay. You'll be fine. All right. No other questions? Are we good to move on? All right, I think we can move on.
So I'll be taking over again, and we'll talk about everyone's favorite organ, the kidney. Wait, why is it not working? Okay. So I'm going to be asking you guys a few questions about the kidney before we actually go into the things first. So we're going to start off general. Okay, so its location in the body, right? So between which vertebral levels do you find the kidneys? T12, L3.
Rapid fire,
Love
mashallah.
that, mashallah. Okay, now with respect to the other abdominal organs or the peritoneum, where does the kidney lie? Retroperitoneum. Good job. Good job. Okay, now the kidney is found between two muscles. Which muscles are they? Or it's placed relatively between two muscles. Okay, psoas. What's the second one? Diaphragm. Okay. Why would you say diaphragm though? Isn't diaphragm at the top? Quadratus. Yeah. So it is quadratus. So it's psoas and quadratus. Okay, so psoas is going to be medially and quadratus is going to be laterally. Okay, and we will go through it. Okay, now the kidney has, okay, so let's just go to the picture. So as we said, T12 to L3, retroperitoneal, and medially, so let's say you have the kidney, it would be here towards here, you would have the psoas major, and laterally you would have quadratus lumborum. Okay? Then you have borders for the kidney, you have lateral and medial border, right? So which border is this? Is it the medial or lateral one? Medium. Good job. And so the other one will be lateral, right? Okay. Then we talk about the poles of the kidney. So this is just really basic general anatomy, okay? You have superior and inferior poles, okay? Now, there was this thing about dimensions. What they're basically talking about is how it's placed in the body. So the kidneys are not vertical. They're kind of like laying to the side of it. Okay, so it's placed obliquely. So now this is the easy part, and I don't think it's that high yield except the part of retroperitoneum and T12 to L3. So if I give you a picture of a kidney and I show you this surface and I tell you what's this surface, you should tell me that it is retroperitoneum. You got this? Medium? What? Do you mean the border? The medium border? Yeah, okay. Tamam. طيب. So we'll go through some differences between the right and left kidney. So first we know that on the right side of the body you have the liver, okay, and the liver is big and chunky, okay, so it pushes everything out of the way. So here it's pushing the right kidney out of the way and it's pushing it down, okay. So it's pushing it down about 2 to 3 centimeters in comparison to the left kidney, okay. Now, because of that, the only rib that protects the right kidney would be your 12th floating rib, okay. Now, on the other side, do you have a liver pushing the kidney down? No. So your left kidney stays up. And so the ribs that cover it or protect it are the 11th and 12th floating ribs. Okay. Did you guys get this part? Because they may ask you, they may get you a picture and be like, oh, which rib is covering this kidney? They won't tell you if it's right or left. Okay, you got this? Good. So again, back to the colorful arrows. I'm going to be asking you guys questions again, and I want you guys to tell me what they are. Okay, so keep in mind we're talking about the anterior relations of the right kidney. Okay, so what do I mean by anterior relations? So the kidney is at the back, it's stuck to the back, and everything that's in front of it. There are things forming impressions on it or just touching it. Okay, so we'll start off with the green arrow. What's the green arrow for? Super, inshallah. You guys are ready. Okay, so I'm good. Good. Type and blue, liver. Okay. And the orange, pancreas. Are you sure? Okay. The person who said colon, you're right. Okay. We'll go through it. Don't worry. Seven. What about the purple? Intestine. Which one? Small. Good. Okay. And finally, the red one. Duodenum. Yeah, see? So this is where the duodenum comes in. Okay, and it's the descending part of the duodenum or the second part. Okay, so again, here we have the green is the right suprarenal gland or adrenal gland. Blue is liver. Okay, kind of looks like the liver. I don't know. You guys see it? Okay. And then you have the orange is the right colic flexure. So this is where the large intestine kind of takes a turn. Purple here is the small intestine. And finally, descending part of the duodenum. It kind of goes with the curve of the duodenum, if you guys see it. How can this be tested in the OSPE? Okay, so like I showed you, like literally, they'll get you an arrow and they'll be like, what's the impression here? Okay. They won't even tell you it's the right kidney. They'll tell you what's the impression here. Okay? Did you understand what I mean? I mean, if it will be shown on a picture. Yeah, so it will be shown this way. Okay? Like without any labels or anything. They'll just point or even like put a number. How can you know if it's right or left kidney? We'll go through that. If it shows on a cadaver, okay, so it will be a picture of like it will be clear. Okay? Don't worry, like they will label it or they'll put a pin. Okay, so sometimes they like using pins. They'll put a pin just like this, and they'll tell you what's the impression here. But they won't put something that's really complicated, you know? Like they'll probably ask you liver. Did you get this part? And we'll go through how to know if it's right or left kidney, like in a while. Yeah, okay. So now left kidney. Okay. Again, I want you guys to tell me. Let's start off with the blue arrow. Which one is this? What's the impression here? Suprarenal gland. Okay. Left suprarenal. Good. I was gonna say you have to specify which one. Okay. Good. Now the orange one. Stomach. Are you sure? Pancreas. We're getting many different answers. Okay. So spleen is the correct answer. Come on. The green one is the stomach. Okay. So remember, spleen is more to the lateral side of the body. Okay. And it's more behind. So this is where it would be. Okay. Now stomach is here. Okay. It's more like medial relative to the spleen. Okay. Now purple is the third answer you guys sent, which is pancreas. Good. Good. Okay. So pancreas is more towards the center of the body. Okay. So, like, what about the red? Okay, colon. Didn't we say spleen? About which one? Red? No. Spleen was the orange one. Spleen is up. Okay, spleen is high up in the abdominal cavity. Red would be like Sidra said, the colon. Okay? So particularly the left colic flexure. Okay? Did you get this part? We'll go through it again.
Guys, I just have one question. Since you guys haven't done GIT, usually renal has been given after GIT. You actually know the things that we're referring to when we're talking about the splenic flexure and the hepatic flexure. And did they mention to you any of this? Or are you not aware what we're even referring to?
Did they just like throw names
No.
of organs to you guys?
Nah,
No.
that's amazing. I love that so much.
Oh, that's sad.
Okay.
High school.
No, okay, so I'll add a slide at the end of this just to show you guys everything. UPP. Yeah, well, not everyone got through UPP or like actually went through it. So I'll just add a slide at the end to actually show you guys everything that we're referring to since you haven't done GIT. We apologize, like that's not something that we could have known. We thought they'd tell you guys. So yeah. We'll just add that at the end, so guys stick around, okay?
But the fact that you guys actually remember these things without having, like, without even knowing what the organs
Very
are,
impressive,
it's
Michelle.
it's amazing. So we stopped at the red. We said it's the left colic flexure. Now the pink. What would the pink be? It's a bit more down. Large intestine. Okay. Yeah. You're close. Okay, so it's the descending colon. And finally, this one, the yellow one. Small intestine. Good. Okay, good. Jejunum. Okay. So here we have the parts again. Above is the left suprarenal gland. And then you have here spleen is more to the outside and more up. Stomach is here. Okay, the green one. And then purple is pancreas. Red is left colic flexure. Okay, and pink is the descending colon. So the colon kind of go like this. Okay, and yellow is the jejunum, which is one of the sections of the small intestine. Okay, good job. Do you guys have any questions on this part or the other relations? Oh, good, good. Okay, so we come to another part. So if I'm being mean, which kidney is this? Is it the right or left? Right. Good job. Good job. Okay. Now, if I want you guys to tell me something about the hilum or the order of the vessels in the hilum, what would you tell me from anterior to posterior? Wow. You guys know everything.
I don't know why we're giving this
Like,
session,
honestly, we really don't have
honestly.
to. Good, good. Vein, artery, and pelvis. Okay, so again, order from anterior to posterior is the renal vein, renal artery, and renal pelvis or ureter. Now, why did I say pelvis or ureter? Because pelvis is more deep inside the kidney, and this would be related to the sinus, the renal sinus. Okay, and we'll go into those details later. But ureter is more to the outside, it's kind of here. So this is related to the hilum, like the actual hilum. Okay? So the big question, how do you know if it's right or left? Okay, so here these are obvious, right? But they won't give you both together. They'll give you separate. Okay, so one thing you guys knew, which is the order of the vessels, which is the toughest one. Okay, so again, vein, artery, ureter. Okay, that's from anterior to posterior. Okay, so this helps me know if I'm looking at the kidney from the front or the back, right? The vein is median. What do you mean? You mean it's towards the medial side? To the center. In the center? The hilum is medial. Okay.
It's medial.
Yeah, it's medial with an L. Okay, so here, you see? medial with an L, okay? Because when you say median, it means middle, okay? So we prefer to use medial, which means towards the inside, okay? Okay, good. So yes, you got it, okay? So the hilum is medial. Okay, so when I get a kidney and I look at it, I'm like, okay, where's the medial side? Is it this? Is it that? Okay, and I look at the hilum. I find the hilum. Okay, I'm like, okay, so this is medial. So I place it like that. And then I'm like, okay, am I looking at it from the front or from the back? Then I look at the order of the vessels. Okay, the VAP or VAD. Okay, and then I look at the order, and when I see that the vein is at the front, that's where my front, that's where the front of the kidney is. And so I can know if it's right or left. Okay, you guys got this? Sorry, I still didn't get it. It's fine. Okay, we'll repeat again. So, which part exactly did you not get? Like, in general, how to know if it's right or left? Yeah, okay. So, first, will we be shown this in cadavers? Okay, probably, yes, but it will be very clear, okay? Like you will see that the ureter is way behind. Okay, so you would know that, okay, I'm looking at the front of the kidney because here the vein is at the front, right? So let's start from the order of the vessels, okay? Vein is at the front, right? And then you have the artery, and then the ureter is at the back, okay? So if I show you this, you'll know that I'm looking at the front of the kidney, right? Okay, but you're not sure, is it right or left? So look at the hilum, okay? The hilum is always towards the medial side, okay? So the way you flip the kidney, okay, it's gonna be towards the center of the body. Like imagine the vertebra here in the center, okay? Now I want to put the hilum towards the vertebra, okay? In the mock OSPE, they had the kidney turned around for a question. You mean they showed it to you like from the back? Yeah,
They're gonna
okay.
do things like that.
Okay, so if you know it's from the back, okay, then you'll see the ureter at the front, right? The ureter will be the closest thing to you, correct? So that way you will know that you're looking at the back. So the way you position the kidney, you would think that it's the opposite, or you're looking at the person from the back. How can you know what the vein, artery, and ureter look like in cadavers in the first place? So, uh, I wish we had a picture. But veins are usually, you know, veins, they're very flat, okay, and they're thin. Okay, collapsed. Yes, collapsed. But arteries are gonna be thick, and they're still gonna have their tone. You know what I mean? But ureter is very simple because ureter goes down. Okay, the arteries and veins do not go down; they go horizontally. Okay, and the ureter is gonna be like this thin tube that's just coming out of the kidney and going down. Did you get it? Okay, good. Does anyone have any other question about this part? I'm sorry, I didn't get if it's left or right. Okay, that's fine. We'll go through it again. Come on. So, starting with the hilum. Okay, start simple. Okay, I have a kidney now. Okay, now I want to know, is it right or left? Okay, I want to know how to position the thing, right? So, I look at where the hilum is. Okay, so let's say this is my hand now. Like my hand is the kidney. Okay, and the thumb is the hilum and the vessels. Okay, so I look at the thumb, like the hilum. I'm like, okay, so here's the hilum. Here's where it would be pointing medially towards the body. Okay, so I'll put it like that. Did you get the parts about the hilum? That it's medial? Okay, so the hilum is medial, right? Now I'm confused. I don't know. Am I looking at it from the front or from the back? Okay, so I look at the order of the vessels. تمام? So I look. I'm like, am I looking at the vein, artery, ureter? Or am I looking at ureter, artery, vein? Okay, so VAD or VAP, that mnemonic. Okay, so if I see that the vein is at the front, I know that I am looking at it from the front. Okay. However, if I see the ureter, then I'm looking at it from the back because the ureter is the most posterior thing. Did you get this point? Okay. Okay, good. So based on that and the way I put it, the way I put the kidney, okay, you would know if it's right or left. You got it? Okay, good, good. Good. Yeah, it makes sense. Okay, great. I'm really happy. Okay. I think that's you. Oh, the mutes.
All right, back to my style. That's a lot meaner to you guys. Name the artery supplying the area that is marked as red. Segmental, okay. Renal. That's like me asking, what's this? It's a kidney. Great job. You're not wrong. You're not wrong. Dr. Elena said she won't be asking us this. If you're absolutely sure, then I'll skip over it. But if you'd like me to go over it, then I can very gladly do so. It's very simple. Yes, please. Okay. For those of you that don't want to know it because she didn't tell you to know it, you don't have to focus on this. However, it is something that is very, very simple. So I will just very briefly explain what it is. When we look at the renal artery, we can see that before it actually penetrates and goes inside the kidney to supply it, it is going to give some branches to supply the outside of the kidney. So as it does so, it is going to give a superior, an inferior, and a posterior branch, okay? Now, since I mentioned posterior, then I have to have something that is also anterior. However, the anterior branch is once again going to split into two. So based on those names, very slowly, let's go through it. I have my renal artery coming out at L2, as you guys said. And then it's going to give me a superior branch that goes up to supply the superior segments of the kidney. It's going to give me a posterior branch that is going to supply the entire posterior aspect. So all of this, okay? And then we're going to have the inferior that goes inferiorly and supplies the entire inferior portion. However, for the anterior portion, we are going to have a split. So since we're splitting into two, one is going up and one is going down, it is also going to be a anterior superior and anterior inferior. All of these are called segmental arteries. And the reason why is because they segment your kidney into different sections. All right. So based on this blood supply, you have segments of your kidney where you're going to be having these different arteries. Is that clear for everyone? I don't want to spend too long on it if she said she's not going to get questions from us. Very passionate about skipping, mashallah. Yes. All right, perfect. That was the one person that told me to explain it, so I'm good. I am glad. All right. This is something that you guys don't have in your slides. We didn't have in our slides. No one has ever had in any slides, but they somehow like to ask about it. So just in case, I didn't put this to scare you guys, but just in case, I added this, just like if you guys were to see it at some point. So name the space marked by the arrow, this space here. Calyx something. Okay. minor. I see where you're coming from, but that's not minor. I will get back to what minor is in a second. Minor calyx. Okay. So I'm not talking about this portion here. I'm talking about this space. Okay, this space. This space is, you guys see these extensions that are going down between these triangular looking structures? The renal sinus, perfect. So these extensions that are going down are basically like our columns or pillars that separate those different triangles, okay? At the end, they're not able to completely reach where we have our calyces, which I'll get to in a second. And because of that, we have this space or a sinus. This is called the renal sinus, and it's at the end of the renal pillar or the renal column. So I'm talking about a renal. How did they ask about this, if you remember? Exactly like this. All of my questions are formatted in the way that doctors would ask about them, so that I try my best to help you guys be able to recognize anything that you see. So everything that I put, the types of questions I put, are what you would likely see on the OSPE. Is that clear? Yes. All right, perfect. Now, I was talking to you guys about these pillars and these columns, and you kept telling me about calyces, 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 minor, right? You're absolutely correct. But these calyces are part of an entirely different network. So our kidney, we're very blessed in the sense that it is divided into two different, let's say, functional units. We have the cortex, which is the outside portion, this outer portion that you guys can see here, as well as the medulla, which you guys can see here. Okay? The medulla has those structures known as the medullary pyramids. These medullary pyramids are those triangular shaped structures with their apex pointing towards our renal pelvis or the ureter, and their base pointing towards the cortex. With these pyramids, we are able to create different lobes within the kidney. I just realized that renal sinus was mentioned in a way as just perfect. Now you know what it is. So these lobes that I'm creating in the kidney are due to those renal pyramids, right? Those medullary pyramids along with the cortex that is surrounding them. Now, those medullary pyramids are going to drain into the calyces that you guys are talking about. So this image shows it much better in the sense that we have these two that drain into one, right? So this would be those three minor calyces draining into one major calyx. And then we have those three minor calyces again draining into one major calyx. Major calyces are going to bind together or fuse to give me the renal pelvis or the eventual ureter. Is that clear for everyone? Where is the renal sinus on this image? It is this space here. So those dips of the renal columns and the pyramids, when they're not able to fully reach these minor calyces, this is going to be the renal sinus. Okay, so this space here, this space here. Short thing. Okay. So our kidney is surrounded by various different capsules in order to keep it in place. Very tightly adherent to it is what we call the renal capsule, okay? This is different than the perinephric and the perinephric capsules that you're going to see on the outside, where you have those fat layers and those insulations that are trying to keep it in place, okay? And this is the general basic structure that we have, where we have these medullary pyramids that drain into minor calyces that eventually merge into major calyces, which are going to go and become our renal pelvis or the ureter. Just a second, sorry. All right, is that clear for everyone? Is everyone good? Perfect. Now, I told you guys that through those medullary pyramids or those renal pyramids, we are able to create lobes in the kidney. That is very important to remember for something that I'm going to be talking about a bit later. Now, let's apply everything that I just told you guys to an actual clinical image. Name the region marked by the arrow here. And what is its embryonic origin? Tricky. If you guys don't get B right, Dr. Paul is going to be very upset. Pyramid, okay. Renal column, okay. I can see that the placement of the arrow is somewhat confusing to you guys, and I'm not gonna lie, I did this on purpose because this is what they do in exams. So I kind of wanted to prepare you guys because a lot of times you're gonna be looking at an image and you're like, I have no idea where this is pointing to. Renal pelvis from the urethric bud, okay. All right, so what type of imaging modality is this to begin with? Ultrasound, perfect. So in an ultrasound, it is not something that is a very sophisticated imaging modality, let's say. It's not able to show you things very, very clearly as much as, like, let's say a CT scan would be able to show. So because of that, you're not really going to be able to see that intricate of structures like the renal column or the pyramids themselves individually. Instead, you can generally see a cortex and a medulla, which look very different in the sense that the cortex is much darker, and then you have the medulla here, and then finally, you see this portion here that's like in the middle where everything is going. This would be your actual renal pelvis and the ureter. So what I am pointing to would be a minor calyx or medulla. Okay, so it is the medulla. Metanephros, perfect. So it's from the intermediate mesoderm. Yeah, I told you that is the medulla. You are correct. Is that clear for everyone? So the outer portion that is darker is the cortex. It is the dense portion, okay? Then this lighter portion here is going to be the medulla that eventually drains into the renal pelvis. Now, if that wasn't clear, I added an image that actually shows you everything, and I tried my best to label everything, where, as you guys can see, the renal sinuses and medullary pyramids are not really that clear. You can't really be like decipher them. However, you can very clearly see there is a cortex, and then this greenish portion is the lighter portion, which is going to be the medulla that eventually drains into the renal pelvis. The embryonic origin is the metanephros, which is from the intermediate mesoderm. Great. All right. Perfect. Okay. Would the light be hyper or hypo? This would be hyper. The light is a hyper echoic. Hypo means there is less sound going through, so it is darker. This is hyper echoic. Good, thanks. All right, perfect. You don't have to know all these details, by the way. Like, I can tell, mashallah, you're working very, very hard, but give yourself a break. You've got this. All right. Now, I took you guys through all of the arteries on the outside that are going to go and supply those segments, the segmental arteries. And I told you guys about the actual structures that are inside. However, what supplies those structures on the inside? Because we need to have a very, very, very rich blood supply to the kidneys. It is going to filter all of the blood, right? So we need to have a very intricate and yet very extensive blood supply system in the kidney. And that brings me to my next question, which is to name this artery. And what does it branch into? So A, name the artery. Anyone has an answer? Arcuate, okay. Any other answers? Or are we sold on arcuate? Intralobular, okay. Interlobar, okay. No idea. I appreciate the honesty, honestly. Like, I'd rather get a no idea answer than just like the lights are on but no one's home, you know? So you guys are absolutely correct. This is the arcuate artery, and it branches into you were tiptoeing around it. It is the interlobular artery. So the way that I like to remember this is we have the renal artery going in. It is going to segment into multiple arteries that are going to head towards different lobes. Okay, lobes, large lobes. Remember how Dr. Annie likes to say that the larger the word, the smaller the structure? So lobe, it's a short word, but it's for the larger structure. So we have those segmental arteries that head towards different lobes, and thus they are interlobar arteries. Okay, so following that here, we have this renal artery that gives me a segmental artery that then goes into being an interlobar artery. After going to those lobes, you see how this triangular shape actually also needs blood supply on the distal portion of it. So because of that, these interlobar arteries are going to form into this arch shape. This arch is the arcuate artery. However, we're not done. We also have lobules. We have those very tiny nephrons. We have those very intricate spaces where we want to make sure that this blood supply is reaching. So because of that, this arcuate artery is going to give further branches. We've been to lobes, but what haven't we been to yet? Lobules. Longer word, but smaller structure. So lobules are those very, very tiny individual nephrons where you have like those sections all together. And this artery is going to be able to supply individual ones. So once again, you have the renal artery that goes and becomes segmented. It travels towards the lobes to become interlobar. After that, it arches over the medullary pyramids to give you the arcuate that will then have those interlobular, right? So they're very dispersed. Looking at that in the diagram, renal artery, segmental artery, interlobar, arcuate, and finally interlobular. The veins are going to be the exact same thing, just in the opposite direction. Does that make sense? Yes, sir. Perfect. Would anyone like me to repeat this? What was the answer for B? You tell me. What does the arcuate artery branch into? Interlobular. Perfect. Good job. Wait. Okay. What's happening? Could you repeat that? Perfect. All right. I am here to help you guys out, so I genuinely don't mind having to repeat the concept 1,000 times, as long as you guys are actually able to understand. So let's have this story once again. We have a renal artery that is going in, right? It gave all of those branches outside. We don't care about them. We're caring about the kidney now. We want to filter the blood. So I want to be able to reach those very tiny nephrons where I'm able to actually deliver the blood to them such that they can filter through it, give it back to me, and I'm good to go. So because of that, I need to reach something that is super, super, super tiny. So every time you think, oh, I'm done, there's a further division, which kind of gets annoying, but this is why I'm telling you guys to follow along with the story. We have the renal artery that is going to become segmented. It is going to give its different segments. These segments are going to seek out different lobes within the kidney, or these different medullary pyramids. As they seek out those lobes, they become the interlobar artery. So inside the lobes, okay? After becoming interlobar arteries, they reach this point where they're like, well, I can't really keep going forward. There's not really much for me to go. I don't know what to do. So they start to cup around these medullary pyramids. They arch, forming the arcuate. Okay? However, I told you guys, as soon as you think, oh, I'm done, there's still more. You're gonna have to divide even more. So after these arcuate arteries are formed, they still have not fully reached the end of the cortex. Because of that, they will form even smaller interlobular arteries. So a lobe is very large. It has multiple lobules within it. Does that make sense? I have another question if I don't mind. Of course I don't mind. How many slides left? We are on slide 34 of 90. That's a very polite way of saying you're bored. So segmental, intralobular, articulate, intralobular. It's inter, not intra. The difference between inter and intra is basically that, think about mold, which is traumatizing for most of you guys, I understand. But if I'm talking about two strands of DNA, let's say, okay? An inter chain would be between those two. An intra chain would be in the same chain itself. So an intralobular would just be like all the way all around in the lobule. An interlobar or interlobular is a lot more organized and a lot more specific. But you are correct in the fact that it is segmental, then interlobar, then arcuate, not articulate, and then interlobular. You have physiology, unfortunately. Well, physiology is the bulk of renal, for sure. However, if you're able to make sure that you've got the OSPE out of the way, you should be good, inshallah, because it is still like a hefty portion of your final grade. You've got this, don't worry. Jazakallah kul khair. Thank you. Allah yajzak khair. All right, is that clear for everyone? Would anyone like me to repeat this? Would anyone like me to explain it in a different way? All clear. Perfect. I love to hear it. All right. If at any point you guys don't understand anything that I'm saying, feel free to stop me. I am more than happy to repeat, no matter how many times it is. My time is all for you guys today. All right. Moving on. Describe the mass seen on CT. Anatomy. Abscess, okay. A perinephric abscess. Yes, you guys are absolutely correct. So what does peri typically mean when I'm talking about anatomy? Next to, right? So let's orient ourselves slightly at what we're looking at. And this is typically something that I still like to do even to this day. I'm looking at a CT. I look at the posterior most aspect, which is the vertebrae, just so I know, okay, I'm looking at this correctly. And then I try to orient myself, which is right, which is left. If any of you was in pre-med, I taught this myself during the anatomage. So hopefully you guys remember. But as soon as I see the liver, I'm like, okay, I know this is gonna be which side? Guys, right, perfect, okay. So when I'm describing something on CT, I have to be very specific because let's say, for example, someone has a cancer and I just go and I'm like, oh yeah, they have an adrenal cancer. The surgeon would not know which side to open up. So when I tell you to describe the mass, you are very correct in the fact that it is a perinephric abscess. However, it is better to specify that it is the right-sided, okay? So it is a right perinephric abscess. And the reason why we're saying that this is an abscess is because you see this sort of like fluid-filled point here where it doesn't look like anything on this side. This is a normal kidney that we have. This is the spleen. But on this side, it does not look normal at all. It looks this like this super huge structure. And the reason for that is that this fat that is around the kidney might actually become inflamed. It might get infected. It might like, get excessive due to various like plethora of reasons. But once you see this, it is a perinephric fat abscess on the right side. Is that clear for everyone? Is it between the renal capsule and the renal fascia? It is between the perinephric fat and the renal capsule, I believe. The perinephric capsule and the renal capsule. Perfect. All right. Okay. Moving on. Name the finding and how is it corrected? Nephroptosis. Okay. Nephroptosis. Okay. Corrected in surgery. All right. If I told you to be more specific about the surgery, you're absolutely correct. It is by surgery. But could you name the surgery? This isn't high yield at all, but I told you guys we tried to cover absolutely everything, just in case. Nephropexy, perfect. You guys are honestly, mashallah, very, very impressive. Inshallah, you're all gonna get A's. I'm very proud of you all. Okay, so first of all, what modality am I looking at here? We all open this slide. I appreciate the honesty. Dedication, that's true. Okay, so what type of imaging modality am I looking at here? I forgot the spelling. Yeah, fair enough. Okay, so guys, this image, is this an MRI? Is this an X-ray? Is this a CT scan? What am I looking at? X-ray, perfect. And what about this one? CT scan, perfect. Okay, so what I'm seeing here is, you guys remember the position of the normal kidney that Naseel very beautifully taught you guys? The abdomen, okay. What specific vertebral level? Perfect, yes. Look at how proud she is right now.
Guys, thank you.
Okay. So amazing. It's T12 to L3. However, looking at this here, we can see those are the sacral vertebrae, right? We're already curving, we're already at the end. And we have this very abnormal mass sort of structure that is actually a dropped kidney. This is, as you guys very correctly said, nephroptosis. Ptosis typically means drooping or dropped. So nephro for kidney, ptosis for dropped. You correct this by nephropexy, which basically fixes the kidney to the posterior abdominal wall. Okay, amazing job, mashallah. Moving on, since you guys, can this be called ectopic kidney? Ectopic kidney is more of a congenital sort of defect where the person is born with that. It's not in the correct place. This is more of a dropped kidney that was initially normal and then it fell out of place. All right, Staghorn calculi, okay. All right, any other answers? Going once, going twice. Sold on Staghorn, perfect, amazing job, mashallah. Mention its anatomical location. Kidney. Kidney, yeah. I can't fault you, it is in the kidney. Renal pelvis. Perfect. Yes. So we were talking about the calyces, right? When we have those microcalcifications or we have those rocks, let's say, that get stuck in the calyces, we have a calculus. Now, this calculus might get dislodged and go into the ureter and block a bunch of different things, which we will be talking about a bit later, inshallah. However, when we are actually at the major calyces and we have this huge calculus that is forming, it's going to take up the shape of our calyces. And because of that, it forms into this staghorn shape. You guys know reindeer with their antlers. It is very similar and it's a very distinctive type of appearance. So this typically, because of its shape, is not able to get dislodged. It's not able to go into the ureter. And because of that, it gets stuck in the renal pelvis. Is that clear for everyone? Yes, perfect. Okay. Now, we asked, would these conditions be asked in OSPE or MCQ or both? Okay, so the details of the condition, like this slide, for example, you would get in MCQs or potentially SAQs, but more likely MCQs. For OSPE, you would get something like this, where they just show you an X-ray. They don't tell you anything. They just tell you what is going on, what's happening, and where is it. So you might see a calculus, let's say at the pelvic brim, for example. You might see a calculus at like any point in the ureter, and you would mention that this is a calculus, and you'd mention its position. This is a specific calculus that is a staghorn appearance, so it is a staghorn calculus in the renal pelvis. How am I able to tell if there's a calculus? You would have this narrowing after it and this dilatation before it, as well as this like point of opacity that is like super bright compared to everything else. Now, this is in theory. In practice, it doesn't really happen that well, but like you can try, you know. Is that clear? Yes, perfect. Now, because of how high yield this is, although this is not specifically OSPE related, I really wanted to stress this for you guys. I already mentioned all of it, but it's basically when you have these microcalcifications or these crystal formations that are going to aggregate in the kidney. And then these stones, can grow in size until they eventually obstruct something. They might go to the ureter and cause this very characteristic pain, which is the renal colic, and basically like shoots down the back. Okay?
Loin to go.
Loin to groin. Perfect. Yes. Is that clear for everyone? This is a checkpoint once again. If you guys have any questions at all, now is your time to ask them. No questions? We're all good? Okay, hopefully. Would you guys like a break or are we good to go? Should we keep going? Should we push forward? We are on slide 38 of 90. Would you like a short break? Good to go. Move forward and don't look behind. All right, we'll be moving forward. You have to go. Well, thank you so much for joining us while you were able to. I really, really hope that the session has been beneficial thus far. And the recording will hopefully be uploaded as soon as possible, and we'll send you the slides as soon as we're able to, so that you can benefit, inshallah. Best of luck with the rest of your preparation. All right. So with that, we shall be moving to our next section.
Right. So we're moving forward, not looking back. Third section is the nephron. Okay. Now, I think you guys can already guess that this is gonna be highly histology oriented. Okay. I know not everyone likes histology, It's all pink and purple, I know, but sometimes you kind of see it, okay? All right, so okay. First of all, here we have the histology of the kidney. Okay, so this outer part, what is it? I know it's labeled, but what is it? But wait, the real question is, do you want to have? No, it's fine. We're good to go. Yeah. Oh, thank you for asking. All right. So this darker outer part, what is this? Cortex. Good. And what is it significant for? Like, what does it have in it? Medullary ray. Okay. Cortical nephron. Yes. Okay. Cortical nephron's correct. Yes. And so you have the glomeruli and the Bowman's capsule and all that stuff. Okay. Now what is M? And juxtamedullary. Yeah. M is medulla. Okay. And P? Papilla. Good. So it's not pelvis. Be careful. Okay. All right. So this is a picture of a model. I'm sure you've seen it in lab. You have these different lobes, okay, or pyramids, right? And each kidney has about 7 to 8. All right. Then here is one zoomed in. Okay, you can see all the glomeruli. You can see the tubules. Okay, and you can see how here there's a difference between the cortex and the medulla, right? The medulla only has tubules. Okay, and they're only straight. So, did Dr. Annie mention the sun rays? She mentioned that. Yes. Okay. So yeah. Now, final part is this is a zoomed in model on a glomerulus, okay? Now this is just to give you a general overview of what we'll be going through, but now we're starting with the real deal, okay? So I want you guys to help me out. I know this seems like it's very basic, but we need to go through it, okay? So what is this? This little circle. What is that? Glomerulus. Good job. Okay. A stomach. Love that. It works. Okay. Now, what about this tubule? Has certain characteristic, is close. Proximal what? PCT. Proximal ureter?
Guys, please don't write abbreviations in your own
Yeah. If you write PCT, you'll get it wrong. They won't even give you the one. Okay. Proximal convoluted tubule. Okay, you gotta say it. You gotta say it. PT. Say the word. They say the whole thing out. Okay. So this is a proximal convoluted tubule, okay? Convoluted because it's convoluted, you can see it's twisting, okay? And proximal because it's the closest to the glomerulus, okay? Now you go down here. What do you see here? What is this U-turn thing? Okay, this is the descending tubule, you're correct, but yes, loop of Henle. Okay, so we said descending tubule, we said ascending thin, someone mentioned it, okay, and what about this one? This specific section? Thick. Thick what? Pars recta of the tubule. Okay, good. Thick ascending. Good, good. Okay, now what about this? Early distal tubule. Okay, what about how it looks like? Distal convoluted tubule. Okay, okay. Pars convoluta of distal tubule, that is the perfect histological description of this. Okay. All right, what about this one? This big duct. Collecting ducts. Okay. Good job. Good job, everyone. I know this is the easy parts, but you gotta make sure you know the basics, okay? So Bowman's capsule. Okay, now what's the difference between Bowman's capsule and glomerulus? Or what's their relation? Glomerulus includes Bowman's capsule. Okay. Anyone else? Other way around. Bowman's capsule is basically the glomerulus along with Bowman's space. Okay, we'll solve this dilemma. And so you guys are partially, like, I see where you're getting at, okay? But Bowman's capsule, from the name, it's a capsule. So it is covering the glomerulus. Okay, so the glomerulus is on the inside and the capsule is covering it. Okay, Bowman's space is between them. So you have the capsule and you have Bowman's space, and then you have the glomerulus. Okay? Now the whole thing is called renal corpuscle, okay? But we'll go through a picture of it like in details. Okay, so don't worry about it. All right, here, this is a picture just to show you that you guys already mentioned this thing, that you have two types of nephrons. You have cortical, in which it's only mainly in the cortex, okay? And then you have the juxtamedullary nephron, okay, where it goes all the way into the medulla. Okay, this is just something that's there, but I don't think this is how you use in the OSPE. Okay, now this is, again, the glomerulus, Bowman's capsule, all that, okay? We'll start off with the arterial supply of it, okay? So we have the AA. You guys know what AA is? Like, what's this artery called? Or arterial? Afferents. Good, afferents arterial, okay? Do you know from what artery it comes from? What are focused on? We don't do me like that.
Subhanallah.
Yes, but which tiny branch of the renal? The one right before it. Which one? Inter something. Good job. Interlobular. Okay, so interlobular, it's not shown here on the diagram. Okay, but then you go all the way to afferents arteriole. Okay, and then that branches further into this G. What's G? Glomerulus. Okay. Or if you want to be more specific, glomerular capillary bed. Good. Okay. So this is mainly where the filtration happens. Okay, first capillary bed. Good. Good. This is mainly where the filtration happens. All right. So we branched, and we went all the way here. Okay, but then it has to go back out. So in order for them to go back out, they have to merge together, and they go and form EA. Now what's EA? Yeah, efferent arteriole. All right, and now efferent arteriole again branches into P. What's P? Peritubular capillaries. Inshallah, you guys are amazing. Okay, so here are the arteries we've talked about, IA, which is not shown, interlobular, and then afferent arteriole. So you get branching into glomerular capillary bed, and then you get merging, okay, into efferent arteriole, and then branching again into peritubular capillary. Okay? Now, we're not done with the glomerulus again. Okay, but this time we have numbers. Okay, so these numbers denote different things. I want you guys to tell me, what does number 1 signify? No.
The lights are on, but no one's home. They just
Part of the glomerular capillaries. All right, if I want to talk about the epithelium that I have here, with that, there are certain type of cells. They have a weird name. Principle? Podocytes. Good. Good job. Good job. Fenestrated endothelium. Okay. we'll go through that. Actually, fenestrated endothelium is this one. Okay. And then yeah, you're saying then the basement membrane and then the podocytes. Good job. Okay, so you have number one is showing you the podocytes. Okay, so the ones that are towards the space. Okay, Bowman's space. Right. So you have the podocytes, and then you have the basement membrane, and then you have the fenestrated endothelium, which is number 5. Okay. And then fenestrated endothelium, inside it would be the blood, okay? Like within the lumen, okay? You guys got this part about the difference between podocytes and the fenestrated epithelium? Okay, good, good. So we're done with number 1, and number 5. Now we'll go to number 2. What is this? So we said that this consists of podocytes, and if we want to be more specific, it's the visceral epithelium of Bowman's capsule. So wait, I'm kind of confused. What's the difference between 1 and 5? Okay, so 1, so let's say you have a vessel, okay, the blood vessel now. It went into the glomerulus, okay? So you have the blood vessel, okay, and that's number 5, the red, okay, that's what I'm seeing. That's what has the blood, okay? Now this is covered by another layer of cells, okay? This other layer is your podocytes, which are parts of Bowman's epithelium, okay? So it's called visceral epithelium of Bowman's capsule, okay? Yes, no, you're right. Number 2 is the parietal epithelium. Okay, so you know when you have visceral and parietal, remember like in CBP, the pericardium. So you have visceral pericardium, which is on the inside, and then parietal towards the outside. So it's the same idea. Okay, so 1 is your visceral, it's inside, it's covering, it's hugging the vessels. Okay, and then 2 is on the outside, and between them you have a space which is number 3. So what is number 3? Bowman's space. Okay, good, good, good. All right, you guys get this? You guys got the difference between 1 and 5? Okay, great. Okay. Then we have number 4, which is the easy one. What is this supposed to be? So we went from glomerulus to next part of the nephron. Don't say PCT. You have to spell it out. Too long. Okay, fine. I'll give you that. Okay, so proximal convoluted tubule. But if I have to be more specific, like if I want to say it in a histological manner, what would I say? Pars convoluta or recta? Which one? Pars convoluta or proximal tubule. Thank you for writing it out. Okay, so here are the labels. Okay, one is podocytes, again the visceral epithelium of Bowman's capsule. Okay, and so your parietal epithelium would be number 2. Okay, which is, keep in mind they're simple squamous epithelium. Okay, and then you have number 3 is Bowman's space between these two. Then you have number 5, which is the actual vessels. Okay, and obviously they're simple squamous epithelium, endothelium. Okay, you know the endothelium is what's in blood vessels, right? No. Okay. Do I take the silence as a yes? I'll probably take it as a yes. Thank you. Thank you. Yes. Okay. And then number 4 is where now you have everything filtered out and it starts going to the like tubules. And so you have the proximal convoluted tubule. Okay? Is the glomerulus clear? Like this whole thing? Okay. So this is another image. This is more histological. Okay. So we have number 1 again. Do you guys want to go for it again? What's number one? I'm being mean.
Everyone's falling asleep.
Yeah. Podocytes. Good job. Good job. Okay. Now number two would be come on guys, you just answered this. It's the same thing. It's the same exact thing. Parietal. Parietal epithelium of Bowman's capsule. Okay? Bowman's epithelium actually. And then three would be Bowman's space. Okay, guys, I'll spare you. And five would be the other side, that the actual like blood vessels. Okay? Got it? Yeah, okay. Alright, again, so here, okay. Here I'm getting this I think you guys got word of it, but we're gonna talk about a different thing now. Okay? You guys can see that I labeled here different things, right? So we have this is the glomerulus, okay, we talked about it. Okay, but then here we have something, a tubule that comes back to mama. You guys remember that? What is this tubule called? Distal. Okay, distal convoluted tubule. Okay. Now, do you guys have any idea what this MD is? This is a really important thing. Macula densa. Okay. Okay, let me be more mean and ask you, what is its function? Why is it special? Like, okay, it is part of the distal convoluted tubule, but why do we focus on it? Renin, are you sure? Sodium osmoreceptor thing has to do with sodium. Okay, good job. It is an osmoreceptor. Okay. Now the renin you're talking about is the JG, or what is it, you guys? Signals to JG if sodium is low. Okay. And so what is JG first? It's okay. It's okay if you got confused. Juxtaglomerular cells. Okay. So yes, macula densa senses if your sodium's low or high, whatever, and then it tells the juxtaglomerular cells, okay, to secrete. What is the thing that it secretes? Renin. Good job. Okay. Now renin is, we're going to some physiology now. Renin is part of which pathway? Renin, angiotensin, aldosterone system. Okay, good, good. So let's go through the whole thing again. Okay, so you have the nephron, blah, 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 and then goes back as a distal convoluted tubule, okay, but it rests on top of your actual glomerulus, okay? Now the layer of cells that is close to the arteries is called macula densa, okay? And as you guys said, it's an osmoreceptor, okay? It senses the levels of sodium, and depending on the levels, if they're low or high, they will tell the juxtaglomerular cells to either secrete renin or not. Okay, now renin has something to do with blood pressure. You guys know this, the RAS system. Okay, and so yes, this is this part. Okay, was this clear? Okay, good. Good. So macula densa comes back to mama. Okay, it's just to remember that you get it back after the loop has gone through everything. It comes back. Okay, and here are just the labels. Okay, we're going to another section. Okay, so this is again, you guys can, it's already written. This is the cortex and medulla of the kidney. Okay, so we're kind of zooming out again. Okay, now we have CL, okay, which are these parts, and we have MR. Can you guys tell me what CL is? Labyrinth, okay. What's the C then? Cortical, okay, thank you. All right, what's MR? Medullary rate. Okay, so basically you guys are correct. Cortical labyrinth, circles, and medullary ray straight. Okay, so why did I say circles? Because the cortical labyrinth is what contains the glomeruli, okay, and all the convoluted tubules, whether it's proximal or distal. Okay, but then you guys saw in the previous images that the loops and the tubules go down, okay, and they form like straight lines. Like imagine putting them all together, right? So this would form your medullary ray, okay, and it's called a ray because it reminds you of the sun rays, so they're straight. Okay, is this part clear? It's very simple. Yeah. Okay. I'm gonna skip over this. Okay. This is the same thing. Don't worry. I didn't skip anything. It's just the slides. All right. So this is we zoomed in now. Okay. We have this part here and this part here. Okay. So one of them is the cortical labyrinth. Okay. And one of them is the medullary rays. So this section, the one on your left, is this the cortical labyrinth or the medullary rays? Cortical. Good, good. Okay. So how did we know that? Because we can see, we literally see a corpuscle here. Okay. So this can lead you to knowing that, okay, it is actually part of the cortical labyrinth. All right. Now this part would obviously be medullary rays. Okay. But obviously we have to go into more details. Okay. So I'll leave this up to you guys. And now tell me, what is R? I know I already mentioned it, but I want to see if you guys paid attention. Okay, what does it look like? That's what we talked about now. Corpuscle, good, good. Renal corpuscle, okay. A circle. Yeah. Okay, so renal corpuscle, right? Now we said we have the convoluted tubules, okay, whether it's proximal or distal, okay? Now I'm not gonna ask you guys to label them because it's obvious this is proximal convoluted tubule and distal convoluted tubule, okay? But there are differences, okay? So what is the difference, the major difference that you see between the proximal convoluted tubule and distal convoluted tubule? Let's start off with the colors. What's the difference? More pink, less pink. Good. Okay. So this is where we start off. Okay. So proximal convoluted tubules are what we call fuzzy pink. Okay. Now why do we say fuzzy? Because they have a lot of like microvilli. Okay. And so because this part is responsible for reabsorption. Okay. Now that's physiology. Let's not traumatize you guys now. Okay. What distal convoluted tubules are less pink or they're blue. Okay. And they're not fuzzy. All right. Which shows you they have less like sort of electrolyte exchanges or you guys know this better than we do, okay? Set tamam. So this is the cortical labyrinth, okay, or the convoluted tubules area. Okay, now we go to the next part, which is the medullary rays. Okay, now let's start off with PPR. What is PPR? Here. Proximal pars recta. Good job. Okay, so it's the pars recta of the proximal tubule. Okay, now how can you know this? Like, let's say I'm not sure if I'm in the proximal or distal. Okay, the color, it resembles what? The proximal convoluted tubule, correct? They're both fuzzy pink. All right, so that's something that helps you. But here, do they look like they're twirling around? No, it's very clearly straight. Okay, now going here, what would this be? It's blue, it's not fuzzy, but it's straight. Distal pars recta, okay? Or pars recta of the distal tubule. All right, so you guys got the difference now. Now here we have something extra. We didn't talk about that here. What would this be? collecting ducts. Good job. Okay. So if you look at it, you can see that you can actually see a space in the middle. Okay. So this shows that it's kind of thick. Okay. It's wider than the rest. Okay. And we know that the collecting duct is bigger or wider than the other tubules. Okay. Because it's collecting all the urine, right? So yeah, good job, you guys. So these are just the labels. R is renal corpuscle, proximal convoluted tubule, or pars convoluta of proximal tubule, and pars convoluta of distal tubule. Okay, and then we go to the medullary ray. We have proximal pars recta, distal pars recta, which is bluish. This one's pink. And we have the cortical collecting duct. Okay, this one's clear? Is that it? Okay, good. All right, so again, let me not be annoying about it. These are the medullary rays, okay? And you have again, number one, collecting duct. Two would be the distal tubule because it's bluish. And three would be your proximal tubule because it's pinkish and footy. Okay? So the way they would ask you is exactly like this. Okay, they'll show you this and be like, what's label number two? Okay, and then you would say, oh, it's the distal tubule. Okay? Yep. Now we'll go to another concept, same image. I know you guys are bored of it. Talking about a different thing now. Okay, so what I want to point out here is these reddish pinkish cells. What are these? Like when you see pink cells, what would you think immediately? Red blood cells. Okay, good job, good job. So now what we're thinking about is capillaries. Okay. Now why are we mentioning this? It has to be there because we know that we have like blood is very essential in the process of like filtration and reabsorption and all that, okay? And we also have the vas recta, is that what it's called? Those vessels, remember, that surround the tubules, okay? So that's where we're going now. Okay, so one would be, what would one be? If we're talking about the vessels. We have seen this thing so many times. Okay, just straight up, what is this? Forget that I said vessels. Moments, thank you. Okay, so here we're talking about the glomerular capillary bed. Okay, so we're talking about, yes, okay, thank you. Okay, so glomerular capillary bed. Now, away from the glomerulus, okay, we have capillaries. Okay, what would we call these capillaries now? Peritubular. Good job. Okay. Now, two, like both these, this one and that one, they're both peritubular capillaries. Okay, but what's the difference? Like looking at the organization of them, what's the difference? Wait, pars recta was in the tubules. No, they're both actually peritubular capillaries because you see the red blood cells in them. Okay, you see there's a red dot here, and you see here red blood red blood cells, sorry. And peritubular capillaries RBC in one line. Okay, yes, that's true. One convoluted, one isn't. Okay, I'll make this guys easier for you, and this is actually based on the cuts. Okay, so it's not about not about where it is, not about the actual organ or which parts. They're both the same exact thing, peritubular capillaries, but this one is in a longitudinal section, so that's why you see red blood cells going after each other in one line. Okay. But here, it's cross-sectional, right? So it's like you have the vessel and then you cut it like that. Okay? So when you cut it like that, you see like a donut-shaped thing, and you see a circle, and so you only see one red blood cell, okay? Because it's cut in a cross-sectional way. Did you guys get this part? So they're both the same type of capillaries. It's just that the cut is different. Okay? Okay. Good. All right. Moving on to I think the last concept of glomeruli. So we're gonna talk about some hormones, okay? But I want you guys to tell me what each one is. Okay, so let's start with an easy one that we talked about, number 2. Okay, so we can see that this is the glomerulus. Okay, and then we see some cells here close to it. It secretes something. We talked about it. What is it? Renin. Good job. Okay, so what cells am I talking about here? Juxta. Yeah. Okay. So yes, here we. How do I know if it's juxta or macula densa? Okay, macula densa. I'm gonna try to zoom in. Okay, where my cursor is going. Okay, okay, I'll try it from once here. You see this tubular thing? Okay, this is your distal convoluted tubule. Okay, now I know that macula densa is the one in the distal convoluted tubule. It's the layer that's closer to the glomerulus. Okay, however, juxtamedullary cells are part of the glomerulus. They're part of the afferent arteriole. Remember the AA? Okay, before it branches, you have these juxtaglomerular cells. Okay, so the two, okay, I get it. The two is kind of between them. Okay, but it should be here, like a bit lower. Okay, okay, you're welcome. All right, now let's go to number 1. Okay, number 1. What tubule am I looking at? Okay, I hinted it's a tubule. What am I looking at? Proximal. Good job. Good job. Okay, it's kind of hard to notice it here because they're not pink, they're more pale, but they are fuzzy. Okay, so this kind of guides you that okay, it is the proximal convoluted tubule. Okay, now what is significance about here, like in terms of hormones? Vitamin D activation. Inshallah, good job, good job. Okay, so vitamin D activation happens here in the simple cuboid epithelial cells. Okay, with the microvilli. All right. Now, let's go. We did 1, 2. Now let's go with number 3. Okay. We see little red dots. So what are we talking about? See the little red, pink circles? Endothelial cells and red blood cells. Good job. Okay. So yes, the endothelial cell would be this. Okay, the red blood cells would be the pink ones. Okay, God, I hate this so much. I know, it's a lot. It's a lot. But if you take it one by one, like literally, take as much time as you want for it. Take it one by one, and it will go easy. Okay? And do questions. Practice questions. Okay? It helps.
Any tables or Dr. Annie's
Tables.
slides.
Dr. Annie usually sends, like, she gives tables, and they're very important. Okay? All right. So don't worry, we're almost done. Okay. Um, yeah, so going back to these capillaries, okay, so these are actually the peritubular capillaries. Now, what is synthesized here? There's a certain hormone that's synthesized here. Erythropoietin. Good, good job. Okay, I'm really proud of Sean. So this is just labeling what we said. And yeah, do you guys have any questions so far? No? Okay. I just want to tell you guys that we're at slide 50, so we're more than halfway through, which is amazing. Okay, good job. Thank you guys for keeping up with us. Okay, and we'll go back to prep.
All right. So she told you guys that we're almost done with histology. Haha, psych. Next up, we are moving to our next portion, which is not moving in the slides for whatever reason. Okay, there we go. All right. So You guys know my style by now. We have the circle structure. We want to name it. And then we want to know the type of cells that we have here. And I want you guys to be as specific as possible. We're almost done. We're almost done. Okay? So name the structure circled. Papillary collecting duct. Perfect. And what type of cells would I typically find here? Okay, so let's first start with the actual simple columnar with short microvilli. That is absolutely perfect. Bismillah, mashallah. And if I were to call these cells a specific name, do they have a specific name? Light cells. Great job. Now you can see here that they are actually very lightly colored. I don't know if you can see. Yes, you can see my cursor. Okay. These are very, very lightly colored. And if you were to really look at it, you can see that all the nuclei are lined up very beautifully. You guys can see that here as well. And then the cytoplasm extends upwards into like somewhat of a pointed end, right? Well, this is because those are columnar epithelial cells. A cuboidal cell would have this circular nucleus, right? And then going to be like a cube. Well, a columnar epithelial cell has this oval nucleus with this stretched out cytoplasm. Now, after that, I'm looking at the cells. They're very light in color. They look very pale. These are our principal or light cells. You guys are absolutely correct. And as we move from the cortex, which you guys can see is super dark, towards our renal pelvis, we're going to have less and less of our actual convoluted tubules because those are super close to our glomerulus, which is only present in the cortex. And we're going to have more and more of both those collecting ducts and then the super long loops of Henle that dip down. Okay? So when I see something that looks like this, I'm going to start to think of a collecting duct and a papillary one at that, because it is going towards the papilla or the triangle, the end of the triangle within our medulla. Okay? Is that clear? Yes. Principal. It is principal with an A. I hate those two words, but it is principal with an A, okay? All right. Next up, name the structure marked by the arrow and what type of cells make this up. What arrow? That is a very fair point, you know, that's an excellent question. The arrow was supposed to be here. I applaud you for your curiosity. Appeal. So the arrow was supposed to be here. I'm not sure why it's not showing up, but it's supposed to point to this, okay? I'll add that in the actual slides. But it's this. You guys should become psychics. I don't know why you're even asking me, honestly. It's super clear which ones I want. Okay, so name the structure and then the type of cells. Thin loop of Henle, okay. And what type of cells am I gonna see here? Squamous, okay. Is it gonna be multiple cells? Simple squamous, perfect. Nah, yeah, there we go. All right, so let's take a look at the very different things that we have going on here. Looking at this here, we can see that this is a collecting duct with its what type of cells? The principal cells that are light cells. You can see it is a simple columnar epithelium where they have their microvilli, okay? And then we can see those very thin tubular structures, which I told you guys are those extensions of the loop of Henle that dip down into the medulla, okay? These can be seen here as a super thin, simple squamous epithelium, just one singular layer. What else was also one singular layer of simple squamous epithelium that Naseel told you guys about? Flat nuclei, okay, yes. A squamous cell has a fat nucleus. That is the part of what they look like. So typically when I'm telling you guys there's one layer of simple squamous epithelium, I'm talking about a capillary. Now, how am I able to distinguish between whether this is a capillary or it is a turn of the thin loop of Henle or the thin loop of Henle? It is through those erythrocytes that you guys were talking about. It is through those red blood cells. Once I see those red blood cells, once I see those pink cells that are all around going in a line, this I can tell is going to be a capillary. And in this case, it is the vasa recta. Okay, so these are the capillaries that loop all the way around everything. Meanwhile, our loop of Henle is going to be this super thin, but completely devoid of any RBCs. Is that clear for everyone? Perfect. Okay, we have finally made it out of the kidney. Finally, this is our next checkpoint. Do you guys have any questions for us before we move on to our next segment? All good. Thanks for keeping up. Of course. Thank you, guys. Okay. We are 53 slides in. We are at the fourth section out of 8. Well, technically 7, because the last one's just conclusion. So would you guys like to take a short break, or would you like us to keep pushing forward and not looking back? 5-minute break, yeah.
We'll give you that.
Sure. Okay. So we'll take a 5-minute break. Would you guys rather a 10-minute break? Or is 5 minutes?
Push quick after.
Hopefully.
Okay.
This is the heaviest portion.
Yeah.
The kidney has a lot of information. So hopefully afterwards it should be relatively easier to go through. And you guys should reply faster. A lot of the time we're just waiting for responses, so just reply faster. Okay. We'll take a break until 10:30. Honestly, we had a final today. We understand completely.
Sounds mean.
Yeah.
Okay.
Not necessarily. Okay.
So things are gonna start getting relatively more simple from now on. Okay, the
So we're
nephron
gonna
was
try to go quicker.
Yes.
Inshallah.
the nephron was the toughest part. Very detailed. Okay, but
Are you guys actually back? Would you like us to wait for a few more minutes? Are we good to go? Yeah, okay.
good.
Perfect. All right, let's
Okay.
get started.
Okay.
What are the topics left? We're going in order. So we started from the posterior abdominal wall, the kidney, then we're gonna go to the ureter, the urinary bladder, and the urethra and the prostate.
Okay.
Okay.
I think so.
I think that's
Was
good.
he
He was the one
with
for the
silence?
silence means yes.
Yeah.
So we'll just
Is there recording? Is it recording?
okay. Recording, yes.
Oh, okay.
Then OSPE is over. Yes.
Yes.
I love when you're saying OSPE is over, as if we're gonna go over MCQs and SEQs as well.
You're welcome. Okay, so I tried to make this section as simple as possible, okay, but we're gonna go through the relations of the ureter, okay, so basically we're talking about the pathway of the ureter. We know it goes out from the hilum of the kidneys, and then it goes and passes over this muscle. It's labeled, unfortunately, so I can't ask you guys. it passes over the psoas major muscle. Okay, so this is one of the main relations of the ureter. Okay, it passes anterior to the psoas major muscle, it kind of lies over it. Okay, and then the second part that we want to talk about is the pelvic parts of the ureter. Okay, or specifically here, you know the pelvic brim. Do you guys recognize what that is? When I say pelvic brim. Yes, in caps. All right. Okay. So yeah, and the ureter. Oh, that's fine. Okay. So the ureter passes over the pelvic brim, okay, as part of its pathway. And if we want to be specific, it's close to the bifurcation of the iliac, okay, of the common iliac arteries. Okay. So you see the bifurcation happens here, and the ureter passes right here. Okay. So this part's important. All right, so we have two relations again, passes over psoas major and over the pelvic brim. Okay, and then obviously goes through the pelvis and all the way to the bladder. All right, this part's good. You guys are good with it? Okay, moving on. So now, obviously, because this is the urinary system, so there are differences between the male and female relations. So here, this is the male side, okay? Like this is representing the male. Now, there is this thing, I'm not gonna say, okay, that's passing and it's crossing the ureter. Okay, what is it? Vas deferens. All right, good. Ductus deferens. All right. So, yeah, you're right. It's crossed. The ureter itself is crossed superiorly by ductus deferens, so it kind of goes above it. Okay. Now, this is the female side, however. Now we see the ureter here. Okay. But there's this artery crossing over it. Uterine artery. Okay, good job. So yes, it's crossed anteriorly and superiorly by the uterine artery. Now there is some clinical significance regarding this uterine artery and it being so close to the ureter. Can you guys guess what it is? Don't ligate ureter. Okay. Are you referring to hysterectomy? Yes, okay. Yes. So in hysterectomy, sometimes you might cut the ureter by mistake. Okay? Like when you're ligating the uterine artery. Okay? So this is the blood supply of the ureter. Now, if you guys notice, so we have renal, gonadal, lung aorta, inferior vesical artery in the pelvis. If you guys notice, they go sort of in the order of the arteries that we have branching from the aorta, the abdominal aorta. Okay, and Farah explained it beautifully. Okay, so it looks annoying, but just take a put like so first we have the renal, right? So it's renal and then gonadal because we saw that under it. And then abdominal aorta, obviously, because that is where the ureters run. Okay. And then inferior vesical artery in the pelvis. It's kind of weird, but you guys can memorize this one. Okay. However, I don't think they'll be that like strict in asking you, okay, list like 4 arteries, but maybe they'll just be like list two arteries that supply the aorta. So you say, okay, renal and gonadal, okay, or abdominal aorta, for example. All right. Now for veins, your safe answer is to say it's drained by the corresponding artery, the corresponding veins. Okay, so basically, so you have arteries, right? Like when I say renal artery, you have a renal vein. Okay, so that vein is corresponding to the renal artery, meaning that they run together. Okay, so yeah, this is for blood supply. It's a very like a short section. All right. However, this next part is important. Okay, the 3 constrictions of the ureter. So they're kind of in bold, okay, but I want you guys to tell me, like, because here they're written in a certain name, but what's the name that you guys know for the first constriction here? Uteropelvic junction. Okay. Yes, because it's with the renal pelvis, right? Good job. Okay, now what about the second one? The second constriction?
It's urethral.
Urethral. Oh yeah. So you said uteropelvic junction? It's uretropelvic junction. Okay, because utero, that's the uterus. Okay, so be careful, right? Now, it's actually not sacral. Okay, yeah, it is the pelvic brim. All right. So the first constriction is here, pelvic junction or uretropelvic junction, okay, between the ureter and the renal pelvis. Okay. The second one would be at the pelvic brim because it kind of like when you like a sink, okay, and then you lay down like a rope, so it kind of forms a kink in it. So that's your second constriction. Okay. Now the third one would be here, which is it's written wall of the urinary bladder. Okay, so it is when it enters the urinary bladder. So we call it the uretrovesical junction. Okay, vesicle comes from bladder. All right. So these three constrictions, remember them. Okay, because they might ask you list the constrictions of this structure. They'll label the ureter for you. They won't tell you list the constrictions of the ureter. Okay.
These are the most common sites where the calculi also get
Yeah,
stuck.
I was going there. So what is the clinical significance of these constrictions? It's not what?
You don't have lots of different things.
Oh no, it's okay. So the clinical significance of these constrictions is that your kidney stones can get stuck there, but we wouldn't really call them kidney stones anymore. We call them calculi. Okay. So kidney stone calculi are prone to get stuck here. Okay. Yeah. And so let's look at what is this? X-ray with contrast. I wrote it. I shouldn't have written that. Okay. Now I want you guys to tell me, what's number one? Minor calyx. Good job. Good job. Okay. And then number two, major. Good. Number three, okay. Pelvis. Renal pelvis. Okay. Good. Good. I think it would be better that when you answer a question like this, you specify that it's the renal pelvis. Okay. Because you have the pelvis here, like the actual pelvis. Okay. So it's better just be on the safe side, say renal pelvis. All right. What about number four? This one's easy. What is it? Ureter. Okay. Now, something about these images is that, let's say there's a stone stuck here, okay? Would you see contrast flowing down here? Like if there's a stone stuck somewhere, would you see contrast past that point? No. Okay, so that's something to know. That, okay, this is where you can locate where the stone is. Okay? That's another clinical significance. All right, so these are the labels, minor, major calyces, renal pelvis, and ureter. Okay, do you guys have any questions about the anatomy of the ureter? No, okay. All right, we'll move on to histology.
Okay. With how much you guys love histology, I'm sure you're absolutely delighted to see this. But luckily and thankfully, it is just one slide. Okay? So name the organ. This is a dead giveaway, given the section that we're in. But I want you guys to mention its three layers. Ureter, transitional epithelium, muscularis with lamina propria, and adventitia. MashaAllah. Absolutely wonderful. Great job. You are absolutely correct. This is the ureter, and the way that you guys can distinguish it from anything else is that you see this star-shaped appearance due to the coils, because this is a tube that has to have this laxity in order for it to be able to just stretch out enough to accommodate the urine. So it has those coils that allow for more surface area. The three layers are going to be starting from the inside out, the mucosa, okay, and then the muscularis layer, and finally the adventitia. The adventitia is basically this sort of covering on the outside that is continuous with the covering that is of the gut as well. So the periosteum, similar to the pericardium that you guys have seen. The muscularis layer is actually something that differs when I'm talking about the proximal ureter versus the distal ureter. If I'm talking about the proximal ureter, it is going to have two layers, okay? Specifically the proximal 2/3. So before it reaches the pelvic brim, the proximal 2/3 of it are going to have an inner longitudinal and then an outer circular, okay? So LC, longitudinal, and then circular. The distal 1/3, however, is going to have an inner longitudinal, outer circular, and then an outermost longitudinal again. So LCL. Now, the reason why this is important is because the ureter is basically providing a transition from the kidney to our bladder. So throughout its journey, it is going to take the features that it had in the renal pelvis, which is the two layers, and then move down to have three layers similar to the bladder. Does that make sense? Perfect. So without further delay, let us move on to our next section. Do you guys have any questions at all before we do so? This is our next checkpoint. See, we're going a bit faster. No. Okay. Perfect. Moving on. Let's go.
We'll talk about the bladder. Now, the bladder, the most important thing for you guys to know about it is the surfaces. Okay, now that's obviously other than the function and which sphincter is closed and open. Okay, but that's more physiology related. But for OSPE, we need to know the surfaces. Okay, so we'll go to that. Okay, so I know the picture looks a bit deformed. I'm sorry about that, but I wanted to find a really simple picture and one that you guys can actually relate to or might even get in the exam. Okay, so I'm gonna be pointing at things and you guys will tell me what this is. All right, so obviously this is the bladder, right? Now let's start from here. What is this surface? Median. Why would you say median? The surface here. Anterior, are you sure? Superior. Okay, good. It's okay. It's okay if you're not confused. It's fine. All right. So yes, it is superior. Okay, because uh, we'll understand more as we go through all the surfaces. Okay. So this is superior. Okay. Now if this is superior, then what would this surface be? Inferior. Okay. So it kind of has two parts. So it's inferior, lateral. Okay. So why do I say that? Because ladder is like a cup. Okay. So the top of the cup is the superior part, and then inferior lateral. Okay. So it kind of like forms like a base for the bladder, if you guys understand. Okay. All right. So we've covered the superior surface, we've covered the inferolateral surface. Now what about this part at the back? Careful, it's not posterior. Don't say posterior. No idea. Okay, that's fine. That's fine. Okay, so this is actually, this would be the base of your bladder. Okay, well, you'll understand it more when we actually put it in the body and we see its relation to other organs. Okay, but for now, we're just covering the surfaces alone. Okay, so bladder, it joins here to form, before it actually forms something, what is this part? Kind of drains. Neck. Good job. Okay, so yes, this is the neck of the bladder. Okay, and then after the neck, we would have what? Urethra. Okay, good job. Now we have this, like this line here. What would this line be? It's kind of for support, structural support. Ligament. Okay, yes, it is a ligament, and it is the median umbilical ligament. Umbilical median. Okay, yes. So median umbilical ligament. Someone mentioned median before, and I think this is what you were referring to. Okay. All right. Now, final thing, these two things that enter the bladder from up, what are they? This is very simple. Two tubes that enter the bladder. Ureteric orifices. Okay, yes. So this is where the ureters enter. All right. So this is the labeled picture. Okay. So we said we have superior surface, inferior lateral surface, base of the bladder, neck, urethra. And then you have the ureters, you have the apex, and you have the median umbilical ligaments. I forgot to mention apex. All right. Did you guys understand the surfaces? Okay, great, great. All right. Now we'll talk about the bladder relations again, comparing male to female. Okay, so there's a lot of text, but don't worry, guys, it's fine. Okay, it's very simple actually. So looking at the bladder, okay, in males, uh, posterior to it, okay, what do we have here mainly? It's actually written. Vas deferens and seminal vesicles. It's okay.
The old caps
The
in the
cap.
middle.
All right. So yes, seminal vesicles and vas deferens. Okay. Uh, yeah. Okay, and then the seminal vesicles and vas deferens are between the bladder and what structure? So the bladder is in front of these structures. Now what's behind them? Rectum. Good job. Okay. All right. So bladder itself. Now let's look at what's in front of it. What do we have here? What is this structure? Hello. Please tell us. Okay, so this is actually symphysis pubis, okay? It kind of looks like cartilage, doesn't it? Right? And it's right in front of the bladder. Something about the symphysis pubis actually is that you can palpate the bladder from above it. Okay? So this is some way that you can remember it. So you have symphysis pubis, which is the cartilage, okay? And then you have the bladder, and then behind that you have the seminal vesicles and the vas deferens, and then you have the rectum. Okay, so these are like the order from superficial to deep, okay, or from anterior to posterior. All right, did you guys get this part? You're welcome. You're welcome. Okay, now looking at the bladder, okay, it rests on top of something. What is this? Prostate. Good job. Good job. Good job. Okay, and then the bladder, it continues into the urethra. All right. So these are the relations of the bladder in a male. Okay. Now let's look at female. Okay. It's kind of different. Okay. We have this major organ here. What is this? This part. Uterus. Okay. And then if I ask you what is this part? Okay, the rectum is behind the uterus, yes. But I'm asking about this little tube here. It's in front of the rectum. What I'm asking about. Okay, vagina is actually down. It's a bit lower. Okay, there's something between the uterus and the vagina. No idea. Okay, it's actually the cervix. Okay, so usually the reproductive system goes uterus, cervix, and the vagina. Okay, so this is what we're talking about in the bladder. What you have posterior to it is the uterus. Okay, the uterus kind of lays down on the bladder, so the bladder is like a cushion to the uterus. Okay, the uterus kind of sleeps on it. Okay, and then it goes into the cervix, and then the vagina. Okay. Is this part clear? Oh, good. Okay. So as you guys can see, this is a major difference between males and females in relations to the bladder. Okay, and obviously we said behind the uterus and the whole reproductive system of the female is the rectum. Okay, so the rectum is always towards the back. Okay, the rectum actually is kind of really close to the spine. Okay, so that's something. Now again, what is this? Because you guys were a bit confused. What is this structure? Okay, pubic symphysis. Okay, good job. Good job. You guys are catching up. Okay. So how would they ask you about this in the exam? They would, for example, label, like pinpoint this and be like, or they'll give you a bladder and they'll tell you, okay, what are the posterior relations of this? Okay. And they'll obviously specify if it's a female or a male, like they'll make it clear. Okay. So say it's a female, you'll say, oh, okay, it's related to the uterus, cervix, and vagina. Okay. You guys got the relations of the bladder, male and female? Yeah. Okay. Good. Good. All right, we'll move on to arterial supply. Okay. Now, obviously, the bladder is going to be supplied by branches of the internal iliac. Okay, which makes sense. But there are three main arteries that you guys have to know. So we have superior vesical, obturator, and inferior gluteal. Okay, now there's no way about this. You guys have to memorize these. Okay. However, this difference between males and females is really important. Okay, so there's actually a fourth artery. So they're not just three, they're four. Now, in males, so superior vesicle, from the name, it supplies the superior part of the bladder. Okay. Now, the lower part of the bladder would be supplied by the inferior vesical artery in males. Okay. Keep this in mind. So superior vesicle, inferior vesicle in males. But in females, you have the vaginal arteries instead of the inferior vesical arteries. Okay? So this difference is really important. All right? So let's say they label the base of the bladder and they're like, for example, which artery supplies this in males? What would you say? Inferior vesicle. Okay? And then if I said in females, it would be the vaginal arteries. All right? Yeah, it's pretty much one. Yeah, exactly. Okay. Like we just put it for you for the sake of completion. All right. Venous supply, again, corresponding arteries, and these go all the way back to the internal iliac vessels. I think they said it's gonna come. Oh, like the arterial supply? Yeah. Okay. So you guys should memorize this. All right. Moving on. So the bladder has layers. Okay, this is mainly histological, but you kind of do see a difference in like gross appearances. Okay, so again, you have ureter, you have peritoneum. Obviously, peritoneum is cupping the bladder from the top only. Okay, and then you have the detrusor muscle, which is the main muscle that's acting in the bladder. Okay, so when you want to void your bladder, the detrusor muscle contracts, and so you can void, right? Okay. Then you have the urethral openings. Okay, so this is kind of where the ureters come in. Okay, and then you have the sphincters, internal urethral sphincter and external urethral sphincter. Obviously, you guys have to know which one's voluntary, which one's involuntary. Do you're going over it? Okay. So we'll go over it in the histology part. Yes, and again there is histology. Okay. Uh right, okay. So I'll just skip over this then. Yeah. So we can move on. We can move on.
All right. Okay. So I hop onto every and any opportunity to talk about anything nerve and neuro related. So you guys are gonna have to bear with me. We're gonna be talking a bit about physiology. Trigon, perfect. Yes, we're gonna be talking a bit about physiology in a second. It is something that is super, super high yield. So even if you don't get that exact concept in the OSPE, it is gonna be in your exam somewhere. Okay. So this is the trigon. What is its significance? Why am I talking about the trigon? Why is it different than the rest of the bladder? Hopefully the silence is because you guys are typing like a very elaborate answer. Super, like in your heart and soul. It has the detrusor muscle, but the detrusor muscle is actually surrounding the entire bladder. Okay. So you guys can see here. It surrounds the entire bladder. If I only had a detrusor muscle at the trigon, how would I be able to actually void the bladder? So think of it this way. I have this triangular space, right? This space is going to be the only one contracting. Otherwise, like everything else isn't going to be able to. So that is not the reason. Has the orifices. Okay. So first of all, you guys see this like rugated, like rough edge of the entire bladder, and then this very smooth surface that we have here. And this lies between the two urethral, the urethral opening and the two ureteric orifices. Okay, so these are the two openings that we have from the ureters, and this is the urethra. This trigon is the smooth triangular area that is basically going to be very important for sensing when someone is ready to urinate. Prevent urine reflux, maybe. Prevention of urine reflux is typically important when I'm talking about males and the prostate and so on and so forth. And that is more to do with sphincters rather than with the actual trigon. The trigon, with how smooth it is going to sense when enough urine accumulates in the bladder such that it tells you, okay, this is time for you to go to the bathroom, this is time for you to void. Does that make sense? Perfect, okay. Now, this trigon is also an important landmark during cystoscopy, which is basically an imaging of the bladder, where you're able to see the trigon and then use that as your landmark to locate everything else. Okay? Next up. Perfect. Okay. Name X and Y, and what is the nerve supply to Y? Now, this is an actual question that we got on our exam. Neck of the bladder. Okay. Is this X or Y? X internal urethra. Okay. X, all right. What about Y? Okay. So remember the sphincters that I was telling you guys about. These sphincters and any sphincter in the body is basically the site of constriction that only allows flow one way. Okay, so you have a sphincter in the stomach, you have a sphincter in the anus, you have a sphincter in multiple other places where they will only allow the flow to go one way. So those sphincters are what I was telling you guys are what prevent this reflux of urine. When looking at X, it looks like I do like understand where you're coming from, the urinary neck, okay, like the neck of the bladder. However, you see this muscle that's twisting around it. This is the actual internal urethral sphincter. Y is below this structure here. What do you guys think this structure is? This is a male. That's a big hint. What is inferior to the bladder in a male? Prostate. Perfect. So right below the prostate in males is where we are going to have this external urethral sphincter, okay? The internal urethral sphincter is involuntary in the sense that once this trigone of the bladder senses enough urine, it is going to involuntarily induce urination in the sense that it opens. However, thankfully, we are not the type of creatures who just go around peeing everywhere. We are able to control ourselves. We're able to wait until we get to the bathroom. And the way we do that is through the external urethral sphincter, okay? So the external urethral sphincter is the one that is voluntary. And you guys, one of you mentioned that the supply to the external urethral sphincter is the pudendal nerve, and you are absolutely correct. This is where I was telling you guys I'm going to hop on to any and every opportunity to talk about nerves. So very, very briefly, I promise it's brief. We will be talking about the actual process of micturition. And the reason why I'm going over this is that usually people have somewhat of difficulty with this lecture, although I don't think it is actually that complicated. I am now a person that is in a fight or flight situation. Okay, I am super stressed out. I have so much to do. I have so much to go around. Would I need to urinate in such contexts? What do you guys think? Would you like me to repeat? No? Okay. Are you guys alive? Please. I cannot think at the moment. Honestly, completely understandable. I can do the thinking for you. You've done enough, mashallah. So think of it this way, okay? And don't confuse this because I used to confuse this myself. Sometimes we might think that if someone is like, you see a bear or you see something that is super, super frightening, you might urinate, right? You might like involuntarily do so. But that is not actually what we typically like to think about. If I am in a fight or flight situation, i.e., I am using my sympathetic system, I am on the go, I am super busy, I have a lot to do, I'm like super stressed out, I do not have the luxury, let's say, to urinate. So in that sense, the sympathetic nervous system is something that is going to stop me from urinating. So because of that, I want you guys to think about the effects that it's going to have on the bladder muscle and on the sphincters. If I don't want to urinate, then I need to keep that sphincter closed up, right? And I don't want to urinate, so I'll need to keep the muscle of the bladder relaxed because otherwise, if it's contracting, it's going to push the urine down. Does that make sense? Yes. Okay, perfect. All right, now the actual supply by the sympathetic nervous system to the bladder is through the hypogastric ganglion, okay? So the hypogastric nerve of L1, L2 is going to go and supply the internal sphincter, and it's going to go and supply the urinary bladder. It's going to have different effects in the sense that at the urinary bladder, it will cause it to constrict, and at the muscle, it is going to cause it to relax. On the other end, we have our parasympathetic nervous system. Our parasympathetic nervous system is the rest and digest. So I am super lax, I am chilling, I am vibing, I'm going around, I'm like eating, I'm salivating. And because of all of that, I will have to urinate, right? I'm relaxed, nothing's stopping me. So our parasympathetic nervous system is going to stimulate micturition through relaxing the sphincter as well as contracting the bladder such that it is able to actually void all of that fluid that is inside of it. Does that make sense? Yes, perfect. Our parasympathetic nervous system is going to supply the urinary bladder and the internal urethral sphincter through the pelvic nerve, okay? Now, I mentioned to you guys that the internal urethral sphincter is one that is involuntary, so it would make sense for our autonomic nervous system to be handling it. However, our external urethral sphincter is one that is voluntary. Thus, we need a somatic nerve to supply it. Because of that, we have our pudendal nerve. It arises from the same origin as the parasympathetic nerve, S2 to S4. However, it is a somatic nerve, which is pudendal, and it is also from S2 to S4. Is that clear for everyone? This is a very important topic. Would you like me to repeat anything? Is everything clear? People are sleeping. I understand. We're still in uni, by the way. Like it's we've been here since like 7:30 a.m. All right, so I'll move on. Anything and everything has to have histology that links back to it.
You're welcome.
You're welcome. You're so welcome. I just really, really hope that it's helpful. All right, so name muscle A. So this entire length is muscle A, and mention its innervations. You guys have to be pros at this by now. Detrusor muscle, perfect. And then its innervations should be both sympathetic and parasympathetic, right? So what did I tell you guys is the sympathetic? Pelvic nerve and hypogastric. Perfect. Absolutely wonderful. MashaAllah. Sympathetic is the hypogastric nerve. The parasympathetic is the pelvic splanchnic nerve from S2 to S4. Absolutely wonderful. I'm not going to stall so that we can move on. All right. Last slide before we do a checkpoint. Name the type of epithelium. Transition. Immediately. Absolutely correct, mashallah. Transitional epithelium is very unique to the bladder because it transitions from being this bulging, like chunky cell that is globular and then like cuboidal when the bladder is empty to flattening out and becoming squamous and having like this umbrella type of shape and like just filling out the entire bladder. And that is why it's called the transitional epithelium. You're absolutely correct, mashallah. All right, we have reached the end of this section. Do you guys is exam tomorrow or after tomorrow? It is after tomorrow. I really appreciate the fact that you're staying despite how tiring this is. But you've got this, inshallah. We've attached our phone numbers at the end of the presentation so you guys can reach out and we will be more than happy to help at any and every point. Like it feels like just yesterday that I was in your shoes, honestly. Like I can't begin to imagine how I'm now a third year. Do you guys have any questions before we move on to the next section? We're almost done, guys, I promise.
We have less than 20 slides.
We have less than 20 slides left. Okay, all good. Perfect. All right, so let's move on to our next section.
Which is the prostate. Okay, so did I?
You start?
Yeah. All right. So prostate. Now this part, even though it's a very, very small organ gland-ish thing, okay, it's very important, okay, and it causes many things. And we will be going through them briefly. Okay. So first, obviously we have to talk about the structures that pass through the prostate. Okay. So again, colored arrows. So the blue one, what structure is this? We talked about it in the relations of the bladder. Vas deferens. Okay, good job. Good job. Good job. All right. Now the pink is seminal vesicles. Good job. Okay. So these are mainly two things that are passing through the prostate, but we also obviously have the urethra. Okay. The urethra is obviously passing through vesicles, the prostate, sorry. All right. Now, this specific image is very, very important, okay? And it has a lot of details, and they're all important, okay? But it is actually much more simple than you guys think, okay? So I'm gonna point out things, and you guys are gonna tell me what it is. I know you guys are tired, I'm really sorry, but because this part is very important, so I need to make sure that you guys know this, okay? So we'll start off with this muscle. What is it? If you guys need a hint, there are two of them. Okay, yes. So this is the internal sphincter. So the bottom one would be the external sphincter. All right. And Farah talked about which one is voluntary and involuntary. All right. Now, obviously, these are like this is the actual what? Prostate. Okay, yes. So these are the glandular elements of the prostate. So yes, it is the prostate. All right. So we're done with outside now. Now we'll go inside. So this part, this kind of elevation. What is this? Utricle. Are you sure this is the utricle? Urethral crest. Okay, good. We'll come to the utricle later. Okay? We're going from top to bottom now. Okay, so we have the urethral crest, and then it goes into what is this part? Before this opening, we have a part here, a dilated part. What would this be called? You guys want me to tell you? Because this one's a bit confusing. Okay, so this is the seminal colliculus. Okay, I know it sounds weird, right? But you have urethral crest and then you have seminal colliculus. Okay, now this specific opening that is important, and someone mentioned it before. What is this? Crests. Well, we mentioned the crests. Yeah. Utricle. Okay, good job. So this is where the utricle comes in. All right. So we have the utricle, and then below it we have two openings. Okay, what are they for? Ejaculatory ducts. Okay, good job. Okay, so this is basically what you have to know about the prostate. Okay, this labeling is very important. They love to ask about the utricle. They love it. Okay, if it's not there, I don't know what would be there. Okay. Yes. Okay. So, like Farah said, the utricle. What's important about it is that it is the remnant of the uterus in males. Okay, so males don't have a uterus, so it kind of like becomes the utricle. Okay. So this is just the labeling of everything we talked about. Okay, is this part clear? Yes, okay, good. Now we'll move on to the lobes of the prostate. Now keep in mind, there are lobes and there are zones. Okay, and you need to know the difference between each. Okay, I know like sometimes you can use them interchangeably, but here in the context of the prostate, do not. Okay, all right. So first we have this blue lobe. Can you guys guess what this is? Wait, let me orient you first. So, okay, you guys already said median. Good job. Okay. I was gonna orient you. We have, this is the anterior side of the body, and this is the posterior side of the body, okay? So yes, this is the median lobe, okay? What about this pink one? Posterior, okay. And the green? Anterior. Good job. Okay, okay. Now, what is this duct passing through? I'm being a bit mean here. What is this? I forgot. Okay, does anyone remember the name? Someone was called. Yeah, ejaculatory ducts. Yes. Okay. Good job. Yes. So it is related to the seminal vesicles. Okay. So yes, these are the ejaculatory ducts. Good job. Okay. So these are the lobes of the prostate. It's very simple, very straightforward. Okay. But the idea is to not confuse lobes with zones. Okay. Now zones have more clinical, have a more clinical aspect. Okay. And we'll be taking that with.
You guys have probably gotten sick of me by now with all the clinical aspects, but hopefully it's something that you guys are able to benefit from, inshallah. So Naseel talked to you guys about the lobes. As for these zones of the prostate, we have, instead of just three, we actually have four distinct zones, okay? I want you guys to mark and name the area associated with BPH. Now, first of all, what is BPH? Because they might just write it this way. And then mark and name the area associated with prostatic cancer. So first of all, what is BPH? No idea. Fair enough, honestly. So BPH is benign prostatic hyperplasia. Let's dissect that. Benign, as in it is not cancerous and it is not necessarily harmful to an extent that it is like affecting a person's life. Prostatic, related to the prostate. Hyperplasia refers to cells that are dividing excessively. They're growing a lot. Okay. So when I'm talking about a benign prostatic hyperplasia, which zone am I referring to? A, B, C, or D? A? Inshallah, that's gonna be you after you leave the exam. You're like, yeah, I got an A. Wait, see, no, let's go back. Let's backtrack. We were doing well. Things were doing. Okay. So what is A? It's A, isn't it? Yes. Good job. So what is A? Which zone is it? Transitional. Perfect. All right. So the way that you can try to remember it is the fact that you have this transition from the bladder to the urethra, as well as you have the transition from the internal sphincter to the external sphincter. And
the fact that this area is commonly associated with this swelling, although it has the actual prostatic urethra passing through it, can give you a hint as to the presentation that the patient is going to have when they come to you. They might come to you saying that they can no longer micturate. They are not able to void, or they're like voiding when they don't want to, or they have some kind of issue with their urethra. And the reason for that is with benign prostatic hyperplasia, you have this constriction at the urethra. Okay? Second point is to mark and name the area associated with prostatic cancer. D, all right? Posterior D. Okay. Is it posterior? Peripheral, isn't it? I love the way Farah has. She's like, it's that, isn't it? It's that one. Yes, it is peripheral. Good job. So it's peripheral in the sense that you can see all of those are kind of coiling into one another, and then this one is like all the way on the outside. And if you got confused, completely okay. And if you were to actually look at a CT scan image, you'd be able to see that it kind of encircles everything else. Okay? The peripheral zone is very commonly associated with prostatic cancer. And this is important because it is posterior, which means that it is closer to the vertebral column. And thus, any sort of metastases, which you guys should know by now since you've done HLS, the zones are central, peripheral, and transitional. No, we will get to that in a second. What's the area associated with BPH again? See, you dig your own grave by asking me such a question because I'm going to ask you to answer. Think about it. Benign prostatic hyperplasia. I told you that you have a constriction around the urethra. So which part wraps around the urethra? Okay, that's very fair. A, which is transitional, yes. I'm not trying to like put you on the spot or make you answer something you don't know. I'm just trying to stimulate your own thoughts as well so that it sticks in your memory better. See, you got it. Transitional, yes. You're absolutely correct. All right. The peripheral zone, as I was telling you guys, since it is peripheral and since it is posterior, it is most likely to develop to metastasize to the vertebral column since it is closer to that. Now, to look at that, actually, we have the transitional zone, the central zone, and the peripheral zone. And then finally, we have this fibromuscular stroma, which is not necessarily a zone of the prostate. However, let's consider it as one just for the simplicity's sake. Okay? Is that clear for everyone? So the transitional zone goes around the urethra, the central zone goes around the ejaculatory ducts, then the peripheral zone is the one associated with prostatic cancers. Okay, moving on. Name the organ. This should be simple. Prostate, perfect. Name the circle structure that is typically found in older individuals. Old prostate, yes, that is true. Now, why did I know that this is an old prostate? What made me think, oh yeah, ugly slide. You should become a pathologist with that answer, honestly. It has the circles, yes. So it has those concentric stones that look kind of like an onion, okay? And this is called corpora amylaceae, all right? What type of epithelium am I typically to see in the prostate? Okay, so since the prostate is essentially a gland, I need to have what is a cell that is able to consistently produce. It is able to secrete a lot. And that is a columnar cell. And they look like they are multiple layers, however, they are not. So it is a pseudo-stratified columnar epithelium. Yeah, it is simple. You are correct. It is simple. It just looks like it's stratified. So it is pseudo-stratified. Okay? All right, perfect. So we have reached the final checkpoint before we end. Do you guys have any questions before we move on to the urethra? Nope, let's go. All right. So the urethra is this organ that basically stems out of the bladder. It carries the urine and it then gets, like, it deposits it out of the body. I'm looking at a male urethra here, and I want you guys to mark and name the area most commonly injured during catheterization. Membranous urethra, number 3. Perfect. Okay. So let's review this very quickly. We have our bladder with the detrusor muscle and the internal sphincter, external sphincter, which we have the prostate between. Okay. So the urethra, as it passes through the prostate, is going to be called the prostatic urethra. All right. Afterwards, we're going to have the membranous urethra, which passes through the urogenital diaphragm, which are basically the muscles that hold up the bladder, the uterus, the rectum, all of the above. Okay? It is the shortest, the narrowest, and the least dilatable part. And because of that, during a catheterization in which they insert a catheter into the urethra, it is very commonly injured. Not only that, you guys can see that it also has this curve. So because of that curve, it's very susceptible to getting some kind of injury. Okay? After our membranous urethra, we have the spongy urethra or the penile urethra. So the spongy one is going to have a bulbar part and then a penile part. The bulbar part is going to be in the bulb of the penis, while the penile part is the actual penis that is extending. Okay? This is the longest part, and it averages to about 15 centimeter in length. And this is where the bulbourethral glands open. And this is basically just to provide some sort of lubrication. It's just there. It doesn't do much for our urine, but it's there for lubrication. Okay? So we start off, neck of the bladder. We go to the prostatic urethra, membranous urethra, spongy urethra, which has 2 parts, the bulbar and the penile part. Is that clear? Yes, perfect. Okay. So let's name the structure marked by the arrow. First of all, is this a male or a female? Female. All right. Okay. So I am expecting the urethra in a female to be much, much shorter. While in a male, just the spongy part alone is 15 centimeters long. In a female, the entire urethra is going to be like 4 centimeters. Perfect. This is the external sphincter. In a female, they're very, very, very close to each other because you don't have a prostate to separate them. So they're almost indiscernible. But this is the external sphincter. You're absolutely correct. Is that clear for everyone? Is everyone on the same page? Yes. All right. Perfect. Let's move on to your favorite part.
And that is histology. Really sorry, guys, but it has to be there. It has to be there. All right. So now I know this is probably shocking. Like it's Annie, okay, Dr. Annie, but uh, her slides actually helped. Okay, especially in this part. I know they might seem like it's too much going on, but we'll follow it one by one. Okay. Is it? Okay. All right. You guys can see the slide, right? The histology slide. All right. Where's the internal? The internal sphincter.
The internal sphincter here would be more towards the neck of the bladder. So it would be around this area. Is that clear?
Sure. All right. Okay. So, uh, now we already talked about the parts of the male urethra. Okay. So we know it has prostatic and then membranous and then penile or spongy urethra. Okay. Now we want to talk about the histology. So how does each part look like? So the prostatic urethra, because it is coming right from the bladder, think of it as in it would still have the transitional epithelium. Okay, so as it says here, transitional epithelium last time. So what we mean by last time is like this is the last time where you will ever see transitional epithelium. Okay, because it moves on to something else. All right, so again, prostatic urethra has transitional epithelium. Okay, got this part? Yes, okay, good. All right, then we move on to membranous urethra and penile or spongy urethra. Now, the membranous urethra is really short, okay? So we don't really talk about its histology because it's very short, but it mainly goes with the penile or spongy urethra, okay? Now, what this would have is stratified columnar epithelium or pseudostratified columnar epithelium, okay? So as you guys can see, it looks stratified, right? So this would be your penile or spongy urethra, mainly. Okay? So again, prostatic urethra is transitional epithelium. Okay? And then penile or spongy urethra is stratified columnar epithelium. Or pseudostratified. Okay? Mainly stratified. Stick with stratified. Alright? So these are the parts of the urethra. Now, obviously the urethra ends as the external urethral orifice, okay? Or meatus, right? So we're going all the way from transitional to stratified columnar epithelium. And then because we're going towards the outside, so towards the skin, the epithelium is going to start to look more like skin. Okay? So what do we mean by that? Go to number 3 here. It says stratified squamous, non-keratinized epithelium. Okay, so stratified squamous is, you know how the skin looks like the layers are very thin, okay, and they're put up against each other, right? So this would be the part that's close to the orifice, okay? But it's still not there. Non-keratinized because it's not skin yet, okay? It's still part of the urethra, all right? So again, 1, transitional epithelium in prostatic urethra. 2, stratified columnar epithelium in the penile spongy urethra, okay? And then 3, which is close to the external urethral orifice, you have stratified squamous, non-keratinized epithelium, okay? Now, obviously, when this finishes, when you reach the outside of, or close to the outside of the body, it switches to skin, okay? And we know skin is stratified squamous keratinized epithelium, so it has keratin. All right, so did you guys get this part? Yes, okay. Let me ask you. What is the type of epithelium in the penile or spongy urethra? Stratified? Which type? Columnar. Okay, good job. Good. All right. All right, moving on. So this is the same idea. Now, which one would this be? It already says it's the penile urethra, okay? Penile or spongy, all right? Part A is the stratified columnar epithelium. We can see that. Okay, that's what we've already talked about. But part B is the lamina propria or connective tissue. You know how like all types of epithelium, they have something around it. It's like supportive tissue, right? So this is what you have here, okay? This part's like, it's basically the same thing as we said before. All right, so we talked about male. Now, female, as we said, is very, very short. Okay, however, it does have differences. So again, transitional epithelium in the first part of the female urethra. Okay, now we're not going to say prostatic urethra because females don't have a prostate. Okay, so again, transitional epithelium in the first part of the urethra. Okay, then in the second part of the urethra, you would have stratified columnar epithelium, like what we saw in penile, um, the penile urethra. All right. So again, first part of the urethra, like you can kind of take it as half and like a bit. Okay. So transitional, and then again stratified squamous, so stratified columnar. Sorry. Okay. Did you guys understand this part? So it's much more simple than the male. You guys got this? Yeah, okay. All right. So, right. So this is the epithelium of the urethra. Okay, but obviously the urethra has muscles around it. So you have the muscularis layer. Okay, so we're going from inside to outside now. Okay, so the muscularis layer has smooth muscles. Okay, inner longitudinal, outer circular. Okay, but mainly what I want you guys to focus on is the type of epithelium in the urethra. All right, did you guys get this part? Okay, good. Now, obviously, you'll ask me, okay, what about the external urethral orifice? It's the same thing as in males. Okay, first you have stratified squamous epithelium with no keratin, and then it goes to keratin. Okay, so it's mainly, if you guys can see, it's a more simplified and shorter version of the male urethra. Okay, is this good? Okay, and with that, we conclude. Good job, guys. Thank you so much for sticking out with us.
Yay!
We tried our best to put everything that is high yield for OSPE. Okay, you're welcome. You're welcome.
Now, there was this one point where, because you guys have not done GIT and we were talking about the relations of everything with everything, so we added this one slide just for you guys to actually be able to see. So here we'd have this kidney and this kidney. This is on which side? This is the right side. It's slightly lower because of the liver. And then you guys can begin to see these structures around it. So this extending cane-looking structure is the pancreas. This flip here, this twist is the duodenum. And then the spleen would be around this side here. Okay, the spleen would occupy this. The splenic and the hepatic flexures are basically when we have the colon or the large intestine that goes up, and then at the liver, which is hepatic, it flips this way, and then at the spleen, it flips this way. So the large intestine is going to go up, across, and down into the rectum. Okay, so this is why you have the hepatic flexure and the splenic flexure. And it's like I just thought giving you guys this image might be a bit helpful to try to visualize the relations with everything. Okay, now before you leave, please make sure you scan this QR code to give us your feedback. One last question, how was the renal exam in general? Did your batch find the exam okay? Was it hard?
It was a fair exam.
It was a fair exam. I personally really liked it.
It was fine.
I personally really liked the renal exam. There's going to be a lot of questions on acidosis, alkalosis, the compensatory mechanisms and things like that. So make sure that you're just familiar with the pH, you're familiar with the bicarbonate, and so on.
The channels,
The
the
channels.
tubular functions, those are important. Okay, like knowing where the sodium ATPase is, where is bicarbonates reabsorbed, where all these things happen. These are very important.
So physiology should definitely be your focus. For anatomy, inshallah, we covered everything that you guys need to focus on. The slides have more than enough explanation and information, inshallah. So hopefully everything is very clear. And throughout this entire preparation, I've been telling Naseel, are you kidding me? So I had to put some kind of meme at the end. But guys, please make sure you scan this QR code. I am Farah Abul, and
I'm Naseel.
And this was us in our Renal OSPE review session. I really, really hope it was beneficial for you guys. In the blink of an eye, you'll be in our seats of third years, and all of this will have been just a dream. So
And thank you guys for sticking out for so long. It took more than 3 hours.
you guys are the OGs.
You guys are amazing.
You guys are the
Amazing,
OGs,
amazing.
honestly. It is absolutely amazing. Like I will remember your names. Yaqub, Farah, Hamza. You guys are absolutely bomb.
Yeah, amazing, amazing.
Amazing.
Review. Thank you.
So I really, really hope this was beneficial. I apologize about how long we took and the fact that we delayed it. We had a final today, so we needed to prepare. And yeah, please come to see.
Thank you. We will.
After we drive back. Sure.
Yeah. You're welcome. It's our pleasure. We're very happy to
It
help.
has been an honor. If you guys have any other questions at all, please feel free to contact us. I'm not sure why it shifted up, but it's fine.
Yeah, it shouldn't be done.
Please feel free to contact us. We've attached our names and our emails to the title slide and to the slide. We are more than happy to help you at any point.
Yeah. It doesn't have to be OSPE only. You guys want help with
Anything.
physiology? Tell us.
Anything at all. Okay? You've got this, inshallah. We're keeping you in our prayers, and we sincerely and wholeheartedly wish you all the best.
Thank you guys. Thank you.
No, stop the heck recording.